Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars. I'm organizing a second Vice President of the World Federation of Neurosurgical Societies in collaboration with the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies, the CANSA. First of all, I would like it's important to mention that we already organized 40 webinars and 7 educational WFNS symposia since the start of the COVID-19 pandemic. This is webinar number 41, and I would like to express my sincere appreciation to Professor Lucas Rasolik. He's chairman of the Peripheral Nerve Surgery Committee of the World Federation of Neurosurgical Societies, and he is president of the Serbian Neurosurgical Society, for supporting the organization of this event and for giving me such opportunity to have such wonderful collaboration. Let me welcome all our keynote speakers today, Professor Mariano Sokolowski, Vice President of the Argentinian Neurosurgical Society, Professor Robert Spinner, is affiliated to the Department of Neurosurgery, Mayo Clinic, United States of America. Thomas Kretschmer, he is Director of Neurosurgery in Austria. Deborah Garuzu, she's working in Dubai in the Parkview Hospital. Hisham Subki is affiliated to Mansoura University in Egypt, and he is my colleague. Alan Belsberg, he is a professor of neurosurgery at the Department of Neurosurgery, Johns Hopkins University, USA. Christian Hennen, chairman of the Department of Spine and Nerve Injury, Germany. Christopher Winfrey is Department of Neurosurgery, College of Physicians and Surgeons, New York, United States of America. And the last speaker is Carlos Aquives. He is affiliated to the American British Medical Center in Mexico. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. We have very interesting presentations today, and they are divided into 2 sessions, as you can see in the screen. All the presentations are very interesting. We have 400 registrants over the Zoom for this event. We are also doing live stream over the Facebook page of CANS, which can be accessed through this address, and over the YouTube channel of the Egyptian Society, and over the Neurosurgical TV. And I would like to thank John Bennett. He is actually doing a great job. To all attendees, we are glad to get all your questions and comments, and it will be monitored through the chat panel or QA. The moderators of this session will be Professor Lucas Rasolik and myself. This is the type of certificates we are offering, and you can print your certificate electronically through this link. The username will be your email by which you register to this event, and this is the password. Remind you that this event is recognized by the World Federation of Neurosurgical Societies, and this certificate is approved by the World Federation of Neurosurgical Societies as well. Let me announce about webinar number 42, next Friday at our usual time, 12 p.m. GMT, which is going to be done in collaboration with the Neuroendoscopy Committee of the World Federation of Neurosurgical Societies. We have 10 eminent speakers from all continents, and we have very interesting topics about ventricular and skull-based endoscopy. Let me also announce about an important meeting, which is the Third Man's Congress, the Mediterranean Association of Neurosurgical Societies, which takes place in Cairo, Egypt, next October. And it's an important event. However, there is a possibility that it's going to be postponed to the next year, depending on the situation of COVID-19 pandemic. All of you are invited, and maybe it's going to be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much. Now I give the word to Professor Lucas Rasolik to say his welcome note.
Good Good morning, good afternoon from Belgrade, from Serbia, Honorable Professor Nasser El-Ghandour. It is my great pleasure and honor to be a part of this educational activity which you're organizing magnificently all of the time. Impressive numbers, 41 webinars so far, 42 upcoming, 7 educational series. This is great activity, especially in this time. And it is my great honor and pleasure and satisfaction to collaborate with you as well. It is my great honor to address on behalf of the WFNS Committee for Peripheral Neurosurgery in terms of creating such joint venture, which is in our understanding of outstanding importance for all participants, especially young neurosurgeons. I will say a few words in this introduction, which are very well known, that peripheral nerve lesions are a multidisciplinary challenge since they are quite heterogeneous and they are seen by different specialists quite differently. In many European countries and worldwide, neurosurgeons are the main providers of peripheral neurosurgery. However, in some countries, orthopedic and plastic surgeons provide this care. Also, the specialist training in neurosurgery varies across the continents, and these variations are related to entry into a specialist training program, the duration of training. There is no unifying curriculum. The requirements of certification of licensing differ, and there are variations in the levels of operative experience between trainees. Different methods of assessment, including in-training assessment of knowledge, skills, and behaviors, examination, assessment of applied knowledge, assessment of clinical skills, and so on. WFNS Committee of Peripheral Neurosurgery has been intensively working to promote this type of surgery, which is an essential part of neurosurgery, and thereby encourage even more surgeons to start practicing in this exciting area. Historically, relatively few surgeons have been resolute in their dedication to the surgical treatment of peripheral nerve system disorders. However, this trend has changed in recent years, probably due to the work of many pioneers who have revealed the consistently good results that can be obtained with nerve repairs, nerve transfers, and nerve decompressions. We believe that all neurosurgeons must have a thorough understanding of the principles of peripheral nerve dysfunction, clinical assessment, and investigation. Also, we encourage young neurosurgeons to be exposed to the different situation and different thinking, which inevitably leads to the experience. To raise the interest in the field of and awareness about the importance of peripheral neurosurgery, all members of the WFNS committee are dedicated to continuing medical education and participation in webinars, congresses, publishing process, and intensive promotion within national and continental societies. Some of our main goals are improving knowledge and education in peripheral neurosurgery among young generations, multidisciplinary cooperation and collaboration, identifying the needs of developing countries and providing professional support, establishing of unified standards with a level of neurosurgical technologies which will be achievable and applicable in all countries, regardless the current state in which the country is, improving the quality of life and social impact. Even in this pandemic era, we have remained active. In these last 2 months, we have organized 2 joint webinars with ENS Peripheral Neurosurgery Section and the WFNS Global Neurosurgery Committee, which attracted a great attention among participants worldwide. By the end of this year, a new book, Diagnostic Assessment and Treatment of Peripheral Nerve Tumors, edited and written by our group and published by Springer, will be released. We have also increased the number of peripheral nerve sessions within the scientific programs of all major neurosurgical events worldwide. And I would like to draw your attention to the following academic and educational events which are upcoming: online, hybrid, in person. This year is very difficult to claim that one of these modalities will be a standard. So we have a ENS Congress in Hamburg. We have a WFNS Congress in Bogota next year. We have a educational WFNS education hands-on course in Brazil. And all of these events will be distributed and announced on time through our networks. So great results achieved in the last few years encourage us to continue with our initiatives and motivated us to be even more active in the period ahead. I would like to express my personal gratitude to all speakers who are now ready to start with our webinar, all distinguished neurosurgeons from all over the world who will give us their presentation today. And it is my great pleasure to announce the first speaker who is ready to keep on rolling, Professor Mariano Sokolowski from Buenos Aires, from Argentina, to give us his lecture, Difference in the Brachial Plexus Injuries between Germany and Argentina. I'd like to also thank all participants for following us, and I hope that this will be very useful for them and increase their interest to deal with peripheral nerve system disorders. Thank you very much, Nasser. Once again, thank you all.
Thank you very much.
Thank you. Can you hear me
Yes.
and see me? Yes?
Yes.
Perfect. Well, first of all, thanks Nasser and thanks Lucas for the big effort you are performing every day for spreading peripheral nerve surgery all around the world. So this first talk will go over some social and economical factors that might be considered when performing peripheral nerve surgery. So I remember when I was young, when I started with this type of surgery, that I've read everywhere that the most common BPI brachial plexus injury was C5, C6, which is the upper type. Is that true? We started to saw a lot of patients with complete brachial plexus injury. So the main message could be in BPI surgery, there are lots of interesting papers, but we should ask us, after reading them, where do they come from? Sometimes we might be comparing apples and pears. So geography or social economical factors are important. After the good idea, Mario Siqueira and Gregor Antoniadis from Brazil and Germany had some years ago, they started to organize the Sherman meeting, the Sherman South American meeting. So the thing is, in this presentation, is to compare a highly industrialized country like Germany with a big Latin America country, middle income developed as Argentina. So the GDP per capita, as you can see, is 3 times between Germany and Argentina. The life expectancy is not so different. So we took 187 patients with brachial plexus injury, 139 from Argentina, and the rest from Germany. So we studied them in terms of their demographic situation, and we saw that we discovered that Germans were older, 10 years older, near 7.3 taller, heavier, all significantly, than their Argentinian counterparts. So the typical German BPI injury man, which is the most common sex affected by, as you all know, by brachial plexus injury, is a bigger, taller, with a high cylinder motorcycle, which is not the situation in Argentina. So Germans average fewer injured roots, and that's what explains why partial injuries are more common in Germany than in Argentina. They have 7.5 less likely to have a complete brachial plexus injury, and the same goes for the type of injury. More Argentinians had a complete injury. And this is also very bad. 50 of our patients in Argentina were not using helmet at the time of the accident. So we should start, we already did, in fact, to make a big law enforcement toward correcting this thing. And of course, more severe trauma are observed in Argentinians. Germans were more likely to have struck another vehicle, like a moving vehicle during an accident. But by contrast, Argentinians were more likely to strike a vertical object like a tree, pole, or wall. So perhaps they could be under the effects of any drugs or alcohol more frequently than Germans. This has of course legal implications. So to study this is not so easy. Anyway, another example goes for the BMI, the body mass index. If you compare these patients, this kind of patients or eventual patients with this type of patients, if you should decide, of course, you will have to you will decide after some experience to have the right photograph patients, which are thinner, because they react better to surgery. So, for example, in the United States, you can find more frequently this type of patients, or in Argentina also, in comparison with Japan, India, and many other Asian countries. So, let me take out this, I'm sorry, the sound. So, BMI matters, and obese patients have heavier limbs and perhaps weight results. Worse results. So if you compare just musculocutaneous with intercostal impairment, you see that the patients that come from Asia, from Japan, Thailand, Taiwan, who have better results in terms of the results of BMI, of the reinnervation of the elbow, and they also have a lower BMI, body mass index, so they are thinner. If we compare with Western countries, you see that the results, at least reported in the literature, I'm talking about the literature, you see that these results correlate with the BMI, which is above 25. This means most of them are obese, corrected by sex and age, of course. So this was published some years ago in Surgical Neurology International. It's free access, open access. And also we study our patients in terms of their results. And as you can see below in the right side, the heavier limbs have worse results in terms of shoulder abduction. But if you study the elbow flexion, this does not reflect. Why? This is logical, because the forearm is not so heavy in comparison with the whole upper limb. So this was also published. So we should speak about this, because this is also important. Are there some social insurances differences? And I'm going to speak about USA, but of course in Argentina, which has a lot of inequality, as I spoke about before, comparing to Germany, we have also the same situation, or probably worse. But there are socio-economical disparities, and that's why I'm using an article produced in USA, and that's why I'm using this country as an example. And well, just to finish, this comparison between the German and the Argentinian patients, I'm not talking about soccer, I'm just talking about BPI injuries, as you can see, is published in this open access review. So please be careful when you read something, anything that you read published in the literature. Well, be careful, we might be compared apples and pears. Thank you very much for your attention to this talk.
Thank you, Mariano. Excellent presentation. We will have time for discussion. In order to keep the program, we will continue with our speakers. So I would like to invite Professor Robert Spinner from Rochester, Minnesota Mayo Clinic to give us his talk about the evolving role of nerve biopsy.
Let's see, do you see the screen?
Yes.
Okay. Well, I'd like to talk about nerve biopsy. I think ultimately tissue is the issue here. And I'll talk about two different things, one related to biopsy of tumors, and I think there is a role, and the second would be related to lesions, which I also think there is a role. I think why biopsy, and I think ultimately tissue is the issue, and in order to treat, you need to know what you're treating, and whether that's observation, surgery, or other treatments, it all comes down to a diagnosis.
Bob,
Yeah.
Robert, you're not in presentation mode, just so you know.
All right, I tried that. Let's see. How about now?
Perfect.
Thanks. So I got interested a few years ago with a pregnant woman who came to me with abdominal pain. She was aware of a tumor that she had in the lumbar spine. And here was an MRI when things got worse. Here was her baby. And at the time earlier, her lesion was this size. And then at the time of that MRI, it was this size within 6 months. The reading here at our institution was minimal growth of a presumed neurogenic tumor. I was meeting her at that time, and I was concerned that there was more than minimal growth. So at that time, we did a CT guided biopsy, and it came out as a neuroblastoma, not as a schwannoma as it had been presumed. She delivered her baby, had chemotherapy, and then underwent en bloc resection after the tumor had shrunk. And the patient's done very well with a targeted approach to a diagnosis. Now, we routinely biopsy lots of places in neurosurgery. The cavernous sinus, which is a lot harder to hit with a needle than some of our tissues. And we don't usually biopsy nerve tumors. And really, there's been some anecdotal evidence over the years, but I want to at least show you the evidence. And I think people would talk about increased risk of biopsy compared to open biopsy, and I'm not sure that's true. Tumor spread and indeterminate or inaccurate biopsy. And I think if you look at the evidence, there is evidence that, in fact, it is safe and can be efficacious. It's not new. People have been biopsying lesions for 40 years. I think a really good article was from Alan Levy's group a year and a half ago, and they look at the risk of biopsying benign lesions. And I agree. I think you look at their take-home message, and in biopsying benign tumors that appear and seem benign is probably not a good idea because there's a higher rate of problems, including neurologic deficit and pain. So I want to show you a patient that I treated recently, a 51-year-old physician who had a thigh mass. He had few symptoms. He only noted them when he was sitting. Otherwise, he was normal and really was doing very well. Wanted to know why he had some swelling. He had a normal exam, and his MRI showed a 4-centimeter, benign-looking, round-looking, innocuous lesion here in the tibial division of the sciatic nerve. Really appears like a benign tumor. At an outside hospital, he underwent a biopsy, experienced exacerbation of pain and some foot dorsiflexion weakness, and the biopsy came back as indeterminate. So when you look at it, I think clinically and radiologically, there were no red flags. He had a benign nerve tumor, and when the path was reviewed here, it actually was consistent with a schwannoma. But then I had to take out the tumor because he was symptomatic, and what I would say is an easy operation became much more difficult. So here's the patient prone, here's the sciatic nerve, tibial division, perineal nerve, and here's the biopsy site, and you could see the amount of scar. And this was very difficult to get it away from the scar. In fact, the track of the biopsy was really stuck to the opposite side of where the tumor arose. And here's the specimen. And I would just say, fortunately, the patient did very well and better lucky than good, but much more difficult than it should be. So I agree, benign lesions shouldn't be biopsied. The risks of biopsies are increased, the risks of surgeries are increased. The problem is that lesions don't come pre-labeled as benign or malignant. And there are obvious benefits still of knowing whether or not something is malignant preoperatively, because at least at our institute, we tend to treat them. So in real life, here's what we're looking at: benign, indeterminate, and malignant. And you could subdivide clinical patterns and radiologic features, but I would say that we're all fooled, and I don't like surprises except my birthday. So we looked at image guided of indeterminate lesions, and we found out that at times there are reasons to do this when people don't have a clear answer based on any pattern. And I think things continue to get worse because the question is with percutaneous biopsy, what is what? Now, here's a patient in contradistinction. I think all of us would agree probably has a malignant lesion. 52-year-old man comes in with a new mass. He has progressive weakness such that he developed a high median complete nerve palsy, and he had severe pain, and he's taking more opiates over the last few months. And here's the lesion, and it's grown, it's large and immobile. He had a complete median nerve loss and complete sensory loss. Here's the MRI, which even at our institution was read as indeterminate. It has some necrosis, but so do some benign lesions. It's not quite regular. The PET scan was indeterminate, but I would tell you that all of us would think that this is malignant. He got a biopsy and it was a high-grade malignancy. This patient with NF1 was pregnant, and she was told when she delivered, congratulations, you have a newborn baby girl. But while we were doing that, we also found this other large lesion. You should have that treated. So we got an MRI, and here it is. And I think most of you were worried that this is malignant based on the fact that she was having significant pain, though no weakness. But this is an ugly looking MRI scan. She got a percutaneous biopsy, and the first one was non-diagnostic, suggestive of a benign nerve sheath tumor in a patient with NF1. We fused it a little bit differently with one of the PET scans, and it came back high-grade malignancy. So I think the point is that there is a role in malignant tumors, and this can be done safely. So when we looked at our data, the benign, you shouldn't biopsy, the indeterminate maybe, and the malignant ones, yes. Now, there is a learning curve because over the years, there are cases I still don't know where I went wrong. This was a patient with NF1 who had what seemed like neuralgia paresthetica, some numbness, some tingling in her anterolateral thigh. With the NF1 history, she was imaged, saw a round lesion. When I was doing the consent a week before surgery, she said, funny, you know, a few weeks ago, instead of being tingly, it went numb. I didn't make much mind to it. Anyway, I was showing the residents how to tease a neurofibroma out of the lateral femoral cutaneous nerve, and instead of being at a fascicular level, it wasn't coming out real well. So we ended up just resecting the nerve with margins just because it was a benign nerve. And lo and behold, much to my surprise, it turned out to be a high-grade malignant tumor. I was glad I did a wide resection at that time. This patient was thought to have a very benign nerve sheath tumor prospectively, took it out, it ended up being a high-grade synovial sarcoma, not of a nerve, and this patient ended up having to have a wide resection. Retrospectively, the radiologist can read it and say something like, well, benign tumors shouldn't usually remodel the bone here, as in this case. I'm not sure that's true, and I'm not sure there were a lot of red flags. Want to just shift gears to something I talked a little bit about with the webinar series, and this is just of lesions. You know, as neurosurgeons, like Mariano said, you know, we're all brought in with certain truths that may not be truths, and we're all brought up with very simple ideas that sural nerve biopsy is the be-all, end-all for neurologists. So over the years, we've gone to targeted fascicular biopsy because, like Mariano showed, you know, life changes and data is good. So if you have a proximal level injury, biopsying a sural nerve may not be reflective. So the problem is that many proximal level lesions that we see or the neurologists see remain elusive despite everything. A thorough evaluation, an MRI scan of their nerve, and then a distal cutaneous biopsy. The problem is that non-targeted biopsies, even of motor nerves, have a low yield, 35 or 50%. And even empiric treatment, whether it's steroids or IVIG, have risks and costs. So when we look at the historical context, we really never did proximal biopsies because we were concerned with causing weakness and finding a biopsy site, and MRI or ultrasound didn't resolve things well. So historically, the neurologic evaluation included history, physical exam, EMG, imaging first of the spine, and then low resolution imaging of the peripheral nerves, and then a non-targeted nerve biopsy, which we've all done hundreds of times. Life has changed and things have improved. And now we have high resolution MR and ultrasound, and we can do targeted biopsies. And it's really possible to apply everything we've learned as neurosurgeons, basically from the cranium down to the peripheral nerve. I mean, we all use Gamma knife to target lesions. We put on head frames. We do all sorts of stereotactic procedures. And the same thing is as if tissue is the issue, and now we're doing vesicular transfers in patients like an Oberlin transfer with a normal ulnar nerve and stealing a fascicle, then I could steal a fascicle from a proximal nerve in someone who's affected, and I could probably do it safely. So over the years, let's see, this skipped a bit. Let's see. So risks and benefits of this. Over the years, we've done 500 procedures in patients with progressive problems. This doesn't include compressive lesions or patients with obvious tumors. And instead of doing it stereotactically, we could do a 6 to 8 centimeter skin incision around where it's targeted. And without a lot of fuss, we take a long piece of nerve. And here was an early case with early MRI, a patient with a foot drop, 18-year-old woman, over years developed the foot drop. The films here were read as normal. The good radiologists that I worked with looked at it retrospectively and said, oh, on this one cut of 500, you can see asymmetry of the perineal division versus the other side. And on T2, it's a little bit bright versus the other side. She only saw it on one spot. We did a fascicular biopsy, and here was the biopsy. And you could see the abnormal fascicle, long fascicle through a small incision. And this ended up being a perineurioma, which now is very common. And in fact, we've advocated that with classic features, you don't even need to biopsy it because classically the radiology is quite consistent. So when you look at the 500 patients, we have an 85% yield with very few permanent complications. In fact, the 5% complication were minor and mostly transient. And over the years, we've seen things like CIDP and inflammatory source vasculitis. Those are treated differently. In fact, vasculitis gets a different treatment than routine steroids. Perineuromas don't have a treatment with medical ones. People with lymphoma who didn't have a diagnosis of lymphoma, and people with breast cancer who were thought to have radiation. And here's a typical specimen that we would take. And this one shows chock full of inflammatory cells. And here's a patient who was thought to have an inflammatory neuropathy, who had lots of B cells on the CD markers. And here's the patient after getting stem cell transplant, which wouldn't be done typically. And I have 15-year follow-up on this patient who was Schwarzenegger's bodyguard, and he's proud of that and has told his story. And then you see some rare things. And in fact, this is a patient who had a sural nerve biopsy done by a colleague of mine at a famous institution in the leg who had a sciatic neuropathy. And this ended up being an amyloidoma with Congo red. And then you see lots of patients who didn't know about cancer, who were treated either with spine operations, immunotherapy, or anything but what they had, which was perineural spread of cancer. And then you can figure out the mechanism. So what I would say is the evolution is very clear. I think just as imaging has evolved, so too we need to evolve. And I think instead of just doing non-targeted biopsies, we need to do targeted biopsies of either vesicular or pure motor branches or sensory branches. And like the American game of pin the tail on the donkey with the eyes closed, I think you need to open your eyes and use your techniques in high resolution. We've talked a lot about patterns here, whether they're clinical or radiologic, and we all play cards and know the hands of the deck, etc. But it's not the cards you are dealt, but how you play your hand. I think ultimately, you know, data analysis and AI is going to do a lot of this work for us, because over the years, we've seen that there are patterns. Certainly computers and higher resolution technologies can do this for us. Thanks very much.
Thank you, Robert, for this excellent presentation. Like always, very interesting issue for discussion. And as we are just on time for our next presentation, it's my pleasure to invite our next speaker, Professor Thomas Kretschmer from Austria. He will give us a talk about neurogenic thoracic outlet syndrome as not a diagnosis of exclusion. Thomas, please.
So you should hear me now.
Yes.
I'm sharing my screen.
Just turn on your slideshow. Yes. Perfect.
Okay. So many thanks for the invitation. In the next minutes, I'm going to talk a little bit about neurogenic thoracic outlet syndrome. As you're well aware, this is meant to be an abnormal compression and irritation of the lower brachial plexus, if we're talking about neurogenic thoracic outlet syndrome. And it is reported to be much more frequent, with 95%, as compared to the vascular TOS. The problem with thoracic outlet syndrome always seems to be that it's difficult to diagnose. And that's one of the reasons why it frequently is missed as far as neurogenic thoracic outlet syndrome is concerned. And so in our practice, we quite often saw a lot of patients who were not diagnosed for a long time, and as a consequence already had severe atrophy. So the task is in the beginning to exclude tumor inflammation or the more frequent causes, a disc prolapse or distal compressive neuropathies. And when I learned about thoracic outlet syndrome in the beginning, I was always told this is a diagnosis of exclusion. What can be the causes? Also, there can be frequent causes. There can be skeletal and bone abnormalities without going into the details. And there can be a lot of soft tissue abnormalities, which actually compress the inferior trunk or the C8 and T1 root. And sometimes we also see predisposing morphotypes. So it's more frequent in females that are looking quite asthenic and have a weak muscular support. Cervical rib, as the ones that you see on this image, as such, are non-harmful, and they are believed to be to have an incidence of 3% in the normal population, but they are not per se causing harm. So in our practice, we frequently saw TOS patients that had a compression due to a combination of several factors that caused narrowing, and the cervical rib or a broadened transverse process could only be one. So in the beginning, history and exam is very important. You look for the pain pattern distribution, for trigger movements, avoidance behavior, and especially you look for the neurological deficit, which should point towards a C8-T1 loss. So, for example, there is a difference between a cubital tunnel syndrome sensory loss and the one you could find in a TOS patient. Personally, I think there's limited value of the described provocative tests, such as the Roos test or the EASE. And I believe more in deep palpation supraclavicularly on the brachial plexus and in trying to elicit a Hoffmann-Tinel sign. But there definitely is also a role for electrophysiology. From this nice publication, you can see in blue the T1 and in red the C8 responses. In the upper row, the motor responses. In the lower row, the sensory responses. In a left side symptomatic TOS patient. And here you see in the motor part an amplitude reduction that indicates axon loss also for the median and for the motor part as compared to the functioning right side. And here you see the same for the median antebrachial cutaneous sensory nerve response on the left and quite normal amplitude on the right, and the same in the same patient for the C8 sensory response. So frequently electrophysiology can help you. The thoracic outlet can be narrowed in 3 compartments. The nerve surgeon or neurosurgeon most frequently will have to deal with the interscalene triangle. So this was nicely depicted by this publication from Desmonions from 2006, where he compared anatomy and imaging with cadaver sections, CT scan, MRI, and high frequency nerve ultrasound. And so you see here exactly the level of the scalene hiatus. And as you can compare, for example, to the MRI, you see anterior scalene, and you see from top to low C6 to C8, and supraclavicular artery in a nice resolution. But of course, in a living patient, it will not always be that easy. So in principle, of course, it's possible with an MRI to depict the narrowing, but it's not that easy. We contributed with some of our patients to this study, where we directly correlated the preoperative MRI findings with our intraoperative findings. So it's possible, but you need to have a very devoted MRI. On the other hand, a high frequency nerve ultrasound is more and more common, and it's easy to use, and it has the advantage that you always can compare with the not affected side, and also that it's dynamic. So it can be used to diagnose thoracic outlet syndrome as well. And to underline that, I will show you a couple of patients. Here we have a patient with a right-sided TOS with severe paresis, atrophy, and pain. So there was a constriction of the inferior trunk, C8 and T1 by a ventralized and fibrosed median scalene. Additionally, there was a high riding subclavian artery, and there was the tip of the cervical rib between the middle trunk and C8. So surgery from supraclavicular approach via partial scalenectomy, decompressed by median scalene transection, and just removal of the tip of the cervical rib. And this is the ultrasound of that patient preoperatively. So if you're not used to that, it might be quite difficult to actually delineate what you see. But we will see in the next patients that if you know what to look at, it's not that difficult at all. Here we have something prominent, and if I tell you that this is C8, you see that something is severely impinging on C8 in an axial cut. Let's go to the next patient. Here you see the preoperative ultrasound of that patient. This is the subclavian artery. This is C8, and this is a severe compression from medial in between the C8 root, and this is the intraoperative example. Another patient with severe atrophy and pain on the right side is shown preoperatively here. What you see on the right is again the subclavian artery, which is compressed by the ultrasound probe. And here from behind, you see a sharp edge of the median scalene. And this is the picture. And you just saw it over here, and this is the artery, and this is where it rode over. So, other example, this is a patient with a gilled hand, atrophy on the right side, and larger small cervical and a small cervical rib, and a larger asymptomatic cervical rib on the left side. So again, this is the right symptomatic side and the larger rib on the left asymptomatic side. And what we found was compression by a fascial structure. In that patient, we had preoperative MRI and ultrasound again. And what you see here is the right symptomatic side and the left asymptomatic side. Again, you see the artery, and here you see the plexus element and the structure that is compressing from the side and from behind. And here you see the artery, you see the plexus element, and here you actually see the rib, but nothing compresses. If we look on the scan again, I will show you here. You actually can see the artery, and now you see the compression. So if you look at the non-affected side, here again you have artery, rib, and rib not compressing from behind. So other patient, inferior trunk riding on a sharp-edged ligament on the right side. We look on the subclavian artery underneath the inferior plexal element. We see the inferior plexal element, and underneath the sharp-edged ligament. And again, in this patient, the ultrasound, by now you probably already know what to look for. And here again, you see the compression. So just to quickly demonstrate the steps of surgery, we'll go very fast over this. So you see the atrophy in a young asthenic female. You see a cervical rib. That was an additional factor, supraclavicular approach. Dynamic draping of arm in order that you can move it at the end of the operation. Skin incision. You look for the omohyoid. You look for the lateral border of the SCM. Then you look for the artery, and below the artery, you will find the inferior elements. And then you basically have to look what is impinging, if there's something from behind, from anterior, or a combination of that. Sometimes, very rarely, you also have to do some bony work. And in the end, we like to move the arm to actually look behind the costoclavicular space and to see if all the structures are decompressed. We will skip that video. So in the series I showed you from 2009 to 2007, we had 51 procedures and 45 patients. So, and all these had high resolution neurosonography, and we found a match in 93%. And in the majority, we had a combination of different factors that that narrowed the space, like a pincer effect. 88% of these patients improved. And just to show you some more pathology that was pressing on the inferior trunk, broadened transverse process. In this example, a nice Simpson's fascia. In the other example, broadened median scalene with a firm fascial element. We're gonna skip this patient, and sometimes you will we will also use approach alternatives. For example, in the last years, we changed to this kind of approach if we think we have to do more bony work, because this gives us more exposure. Sometimes, in rare cases, a biportal approach might be necessary if you think there's something, some pathology as well in the retropec minor space. Then you can do a biportal approach by adding a subaxillary approach. And very rarely, there's also a dorsal subscapular approach, and a modification of that has been described, which has a lot less mobility than the originally described approach. So to conclude, I think still the clinical clues are decisive, but high resolution ultrasound can reliably depict brachial plexus compression and lesion level, but it needs to be learned. So I think compressive brachial plexus neuropathy can frequently be diagnosed before surgery, and our small series at least supports the role of imaging for pre-op TOS workup. And of course, restrictive are the neurosonographer's level of expertise. And if you're more going in the direction of MRI, the quality of the MRI. Well, many thanks.
Thank you, Thomas, for this excellent presentation. As we announced, discussion will be later. We have two more presentations until the end of this session. I would like to invite Professor Deborah Grozzo to give us her presentation about past, present, and future in brachial plexus surgery. Deborah Grozzo is attending neurosurgeon doing peripheral neurosurgery in Dubai, United Arab Emirates. Deborah.
Yes, hello. It's really a pleasure to be here, and I'd like to say thank you to Professor El-Ghandour and to you, of course, my friend Lucas, for inviting me even today. So I don't know, can you see my screen?
Not yet, just share the screen. We are seeing and hearing you well, but just screen is not still on the Zoom. Now it's okay.
Okay.
Just start your presentation. Yes, exactly. Perfect.
Okay, thank you. So as I said before, it's really a pleasure to be here again, and especially because this gave me the opportunity to see so many friends around the world. So hello, everybody. So my talk is about past, present, future in brachial plexus surgery. Now, Nellie McClung, there was an activist for women's rights, said that people must know the past to understand the present and to face the future. And personally, I do believe that this applies also to the evolution of brachial plexus surgery, If we don't understand where we come from, we are not able to understand the achievements that we accomplish nowadays and what we are going to face as challenge for the future. So it's interesting to notice that the first mention of a brachial plexus injury dates back to Homer in the 8th book of the Iliad, when he describes the duel between Teucrus and Hector. And I think it's also remarkable to notify that for a long time, we didn't even know the distinction between nerves and tendons. That the first surgical repair of a nerve was actually attempted here in the Middle East by the Persian physician Al-Razi. But besides the mention in ancient history, then we have to say that brachial plexus injuries completely fell in oblivion, and we start to talk about them again at the beginning of the 19th century, when the French clinician Flaubert described the presence of root avulsions in patients that had died in excruciating pain consequent to violent reposition of a severe shoulder dislocation. When it comes to surgery, it was Sir William Thorburn that is credited to have performed the first brachial plexus repair at the end of the 19th century in UK at the Royal Manchester Infirmary. And at the beginning of last century, Harris and Lowe were the first one to attempt intraplexual neurotizations in 3 cases. Unfortunately, we have to say that this initial wave of enthusiasm soon faded away because the results were definitely very poor, and they were also associated with a remarkable high rate of complications, including a number of deaths. And therefore, the surgery was progressively abandoned by the 20s. But there was a further knowledge that was achieved in the 30s, thanks to the Italian traumatologist Guglielmo Bonola, that recognized that a motorcycle accident might be related to the etiology of brachial plexus injuries. And in the 40s in USA, Murphy was the first one to demonstrate the presence of post-traumatic pseudomeningocele in patients that had sustained avulsive injuries of the brachial plexus and were affected by severe deafferentation pain. So we have to wait to the Second World War, when Sir Herbert Seddon and his team in UK started to reoperate on brachial plexus injuries again. But again, even this wave of enthusiasm faded away because of the poor outcome. And eventually in 1966 in Paris, during the 10th conference organized by the International Society of Orthopedic and Traumatology, a new universal consensus was reached, stating that the surgical repair of brachial plexus injuries was actually impossible. It didn't provide a useful outcome, and therefore it was suggested that for these patients, the only treatment might be above elbow amputation and the implantation of a prosthetic. So in this kind of situation, the only ones that went on performing brachial plexus surgeries were Japanese surgeons that went on screening the patients with myelo-CT, detecting avulsions, and performing intercostal nerve transfer to restore the biceps function. In the mid-70s, modern brachial plexus surgery was pioneered by Hanno Millesi, that we know introduced the graft nerve reconstruction, and Algimantas Narakas. So thanks to their efforts, we started to consider the possibility to operate on brachial plexus injuries again. However, I think it's undoubted that we have to say that the new era of brachial plexus surgery has been opened by the genial intuition of Christopher Berlin, that I consider the one that realized the Copernican revolution in brachial plexus surgery. So we all know that we all divide brachial plexus surgery in a pre-Oberlin era and in a post-Oberlin era, because his intuition of selecting fascicles from the ulnar nerve, and specifically the fascicles for the flexor carpiulnaris, and then co-opt them to the muscular branches of the musculocutaneous nerve to restore the biceps, definitely have opened a new era. So basically, its genial intuition prompted other surgeons also to design a number of similar techniques inspired by the same principles. And we started to consider that nerve transfers could be definitely the technique to apply in most of the cases, because they would allow us to reach much better results, considering also that the timing for the surgery could be delayed. We know that we can perform surgery on brachial plexus patients, even in patients that have been referred with some delay, whereas the treatment, when it was only the nerve graft reconstruction, was not so valid. We also have to thank the contribution of technology, because with the introduction of three-dimensional MRI and the possibility to perform new modalities of study, like for instance, myelography, neurography, and most recently added DTI, we actually have a much higher accuracy in the detection and in the preoperative diagnosis. So this is what we came from, and where do we stand now? And what are the challenges that we are supposed to pick up for the future? I think the first thing we have to consider is that right now we have a remarkable increase of the epidemiology of these injuries. They are normally considered like 1% of overall trauma injuries in the medical literature, but these data are certainly inaccurate, because we know very well that the two-wheelers motorization in Southeast Asia that is associated to a complete lack of security measures, and also the ongoing warfare that unfortunately affects many parts of the world, are highly contributing to the increase of brachial plexus injuries. And we also have to consider that in addition to the, besides the epidemiological increase of this data, of these lesions, most of these patients are young individuals, just at the very beginning or at the peak of their lives, both in terms of professional and private lives, and therefore the remarkable social impact of these injuries is something that we also have to be aware of. Now, we saw that in the past, the brachial plexus surgery was burdened by poor outcome, and this is what encouraged the mistrust and the reluctance of the medical community to consider surgical treatment for these lesions. Unfortunately, even today, there are a lot of myths and misconceptions about brachial plexus surgery. And we have to try to make people understand what is the real situation of brachial plexus surgery nowadays. First of all, a lot of people are still convinced that brachial plexus surgery is a luxury surgery that can be performed only in high-income countries. But on the other side, I would like you to note that in high-income countries, disabilities may be easily overcome by technology. And if you have a family that is already burdened by socioeconomical difficulties in a low-income community, to have a member with such a severe invalidity actually becomes an additional issue. So probably even in low-income communities, brachial plexus surgery has a role in helping families to overcome their difficulties. Brachial plexus surgery is something that can be performed everywhere because we do not require special equipment. Yes, okay, I mean, we appreciate the contribution of technology, but we have to say that if you are an expert, the diagnosis is still essentially clinical, and the repair strategy is something that you can mainly ultimately decide during surgical exploration. So the other major obstacle that we have is the fact that people are still reluctant, believing that surgical treatment of brachial plexus injuries does not provide favorable results. Now, we really have to consider that nowadays, when we talk about partial injuries, when we consider the results that we are able to achieve in upper brachial plexus injuries, for instance, surgery really can restore excellent function in more than 90% of these patients, and this regardless of the presence of avulsions. And even if we are not still able to restore the function of the lower segment of the upper limb, we can still restore a basic form of bimanuality in these patients with total palsy if we achieve a valid restoration of the shoulder and elbow function. So what are the challenges for the future now? We have, let's say, logistic and technical challenges, and I'm briefly trying to overview them all in this last part of my presentation. One of the first issues that we still have and we have to talk about is that many patients are not given a timely diagnosis and they are not referred to a surgeon specialized in brachial plexus surgery in an appropriate time in order to receive their treatment. We know that time is an essential factor for successful outcome, especially in patients that present root avulsions that unfortunately are harbored in more than 70% of brachial plexus injury patients. And we know that if you have an avulsive injury, the only hope to restore function is just to go for surgery. So we need to understand how to select the candidates for surgery. We need to understand when the patient presents a reversible damage that has potential for spontaneous recovery, or when there is a reversible injury that definitely advocate for surgery. And this is something that requires that we raise awareness, that we spread knowledge related to brachial plexus injuries in the medical community, in the general medical community. The next step is that, of course, we need to recruit and train subspecialized surgeons because brachial plexus surgery is demanding and requires great expertise. And it's not something that can be just left to, improvisation. Lucas already mentioned when he started to talk at the beginning of this webinar that we really need to form surgeons. We need to incentivize the education of neurosurgeons in brachial plexus microreconstruction. But the point is that this is something that is kind of rather easy to be done in our countries, in Europe, but it represents an enormous challenge, especially in countries where neurosurgery is still poorly established. If you consider countries like the sub-Saharan African countries or India, the number of neurosurgeons in this country is definitely not enough even to satisfy the needs of the population for life-threatening pathologies. So you can understand the immensity of the challenge. And another problem is that we all have experience of the fact that in order to have valid results, we need to guarantee our patients access to regular and possibly daily physiotherapy. This is essential to obtain valid functional restoration. Now we have to say, again, if we talk about differences between high income and low or middle income, physiotherapy is really a huge issue there, because if you live in a country where you do not have a national healthcare system, physiotherapy, which is something that has to be done for a long term after brachial plexus surgery, becomes absolutely unaffordable. And also a lot of the therapists are not specifically trained to treat these injuries. So we also have to take care of that. Talking about the technical challenges for the futures. One of the first things I would like to highlight is that right now, sometimes on surgical explorations of complete injuries, we do find a remarkable disproportion between the donors and the recipients. Now, we have tried to resort to artificial grafts, and already on the market, we have nerve conduits. We are trying, for instance, to implement also the use of a cellular allograft, but we don't really get the same security that we get with the autograft. And when it comes to artificial graft, we know that they are usually successful only if the gap is 3 centimeters or long or shorter than that. So now we have major efforts related to nanotechnology. We have scaffolds with functionalized cell binding domains. We have guidance channels. We might also consider sustained release neurotrophic factors. And another help may come from boosting post-surgical renervation chemically through the use, through the administration of molecules mostly belonging to chemotherapeutic agents. But again, these are still experimental steps and we need more evidence of their efficacy. Anyway, we definitely have to admit that the most important challenge that we have for the future is to try to achieve renervation of the hand. Now, valid functional restoration of the hand is something that we have already been able to achieve in partial brachial plexus injuries. As you can see, for instance, in this lady where I perform an Acholi transfer, which is basically a reverse Oberlin, selecting the fascicles for the finger flexors. And you can see that she has definitely achieved a good pinch. But we know that when we try to renervate the hand in total palsy, the results are definitely very poor and not satisfactory. So this is one of my patients when I had performed a renervation of the hand in a total palsy. And you can see that for sure there was that the renervation was achieved, but I wouldn't call this a functional renervation. It's a very primitive and very gross function. And I would say even the results of other surgeons, like for instance, Dr. Wan Shufeng, that is probably credited with the best results for hand renervation, again, show that the renervated hand just present a very gross and primitive end function that eventually is certainly not going to be used by the patient. So we have to understand why is hand renervation unsuccessful. And I think this is when the role of neurosurgeons becomes important. You know, the brachial plexus surgery is performed by surgeons trained from other specialties, like for instance, plastic surgery and surgery, orthopedic surgery. But the neurosurgeons are the one that have the knowledge of the way the nervous system works, and we have emphasized, we have highlighted the importance of neuroplasticity. So the reason why hand renervation is unsuccessful is basically that there is not enough neuroplasticity after an extensive denervation of the brachial plexus. And we know that a large black hole is formed afterwards. So we probably need to focus to try to promote neuroplasticity and cortical reorganization better. And right now, it seems that transcranial magnetic stimulation that has already been tried in other pathologies might have a role. But again, like when I was talking about boosting renervation, we have to say that this is still an experimental field and we need more evidence. And finally, I think probably the challenge, which is the most important one that we have to pick up for based on the opinions of our patients, is deafferentation pain. We know deafferentation pain is probably the major issue that patients face after they sustain multiple avulsions. It's found almost in all patients that presented multiple avulsions. We don't understand yet fully the etiopathogenesis. We know that there is a peripheral mechanism and a central mechanism. And the central mechanism, again, keeps us to consider how important is the role of cortical reorganization. But what we know very well is that the deafferentation pain has a very dismal presentation, and that it completely disrupts the life of these patients because they present they live in continuous pain, worsened in a number of occasions. So most of these patients do not get a valid medical approach. And sometimes even the surgical treatment which is offered to them is not a solution. At present, we know that the only technique we have in our hands is tracheotomy that seems to provide a valid resolution of deafferentation pain after the procedure, but it is associated with a high risk of damage to the lung pathways. And unfortunately, if we follow up these patients, we see that there is a progressive decrease of favorable results. So we still have a lot that we have to find out. So I tried to briefly show we have come a long way. We definitely achieve a lot nowadays, and there are still major challenges that we have to pick up. So thanks for your attention.
Thank you, Deborah. Excellent presentation, like always. We have to keep on time. I would like to invite our last speaker in this first session, Professor Hesham El-Sobski from Egypt, to give us a lecture about non-traction injuries of brachial plexus, and then we will have a discussion.
Thank you, Professor El-Ghandour. Thank you, the organizing committee. Thank you, Professor Lucas, for giving me a chance to be a part of this great event. My talk today is about non-traction injuries of brachial plexus. Now you can
just turn on your slideshow. Hesham, can you hear us? It seems that there is some internet connection problems. Hesham, can you hear us? There is obviously a link connection. Nasser, can you hear me?
So I can hear you, of course.
Yes. Obviously, internet is.
I think he's disconnected because I couldn't find him now.
Maybe his connection is interrupted.
His internet connection is not good.
So
If you'd like to take some comments until Hisham join us again. I think we have Hisham Basuni from Germany. He would like to say any comment. Hisham, are you here? Hisham Sobki, you arrived already? Did you join?
Sorry, now you can hear me?
Okay, yes. Go ahead, please. Share your screen again. Take your time.
Now you can see my slides?
Yes, but maximize the screen, please.
Okay. Sorry, I have some technical problem with the internet connection. Sorry for this technical problem. I'll now start my presentation. Non-traction injuries of brachial plexus. It's quite unfair to categorize traction and non-traction injuries of brachial plexus together, as they have different mechanisms, pathologies, management strategies, and outcomes. Various classifications were used to classify brachial plexus injuries, just as Sedan classification, Sunderland classification, open and closed injuries, obstetrical and traumatic, supra and infraclavicular, pre and post-ganglionic injuries, and complete and incomplete injuries. Despite all these classifications and the categorizations, we consider the key point is the difference between traction and non-traction injuries. The anatomy of the brachial plexus is very complex, and the wide range of motion during trauma or even normal activities makes this brachial plexus is hindered to a very wide range of stresses. This is normally counteracted by free mobility of nerve sleeve ganglion, spinal nerve, and the foramina, adherence of the spinal nerves and transverse processes. So sufficient power should be applied to cause traction of this brachial plexus. This is my first slide. This is the spinal cord, the rootlets, the ganglia, the dorsal root, and the ventral root. We have here the emerging root. The first type of injury is avulsion injury. As we can see here, the avulsion injury will cause discontinuation of the rootlet from the spinal cord with a nerve that seems intact, but it's a non-functioning nerve. The stretch injury will be caused by stretch on the nerve. We have a narrowing on the contour of the nerve, loss of some function of the nerve, so we'll have a partially functioning nerve. In this type of injury, which is rupture injury, we have an intact rootlets connected to the spinal cord, but this ruptured root is a non-functional root, but it is a very good donor for reconstruction. Here we can see, this is a dural sleeve, and this is the attachment of the nerve root to the bone, and this is the attachment of the rootlets to the spinal cord. Here, in partially avulsed injury, we have tear here in the dural sleeve, which will give us the pseudomeningeal seal. Another thing, we will have a loss of this attachment between the nerve and the bone, and we have partial avulsion injury. So this nerve will have some weakness, but is still a functioning nerve. In this injury, the dural sleeve is intact, and the attachment is intact, but all the rootlets are avulsed. So it's a non-functioning nerve without any other sign of injury. As we can see here, this is a myelography showing a pseudomeningeal seal, the avulsed root, and the injury in the cord. It's a very rare type of injury. It's an obstetrical injury, so showing bilateral pseudomeningeal seals. It's a bilateral avulsion injury in a small baby. Another form of MRI neurography showing the injury of the upper trunk, here the intact side, C5, C6, C7, C8, and T1. Now we will shift to the non-traction injuries. Non-traction injuries in our study, including penetrating sharp injuries, fracture of nearby bone, iatrogenic injuries, gunshot injuries, and radiation neuropathy. Here, the anatomy of the brachial plexus, C5, C6, C7, C8, and T1 roots. Here, the trunks, the cores, and the division. The non-traction injury can occur in any part of the postganglionic injury, as shown here in this diagram. As you can see in this photograph, it's an iatrogenic injury. It's a supraclavicular approach for excision of a neck mass, comes out with an upper brachial plexus injury. Another iatrogenic injury, as we can see here, it's an supraclavicular incision with for excision of a tumor, but we still have some brachial plexus injury after. This is an assault, this is an injury, this is a sinus, a stab wound here with a neurological injury. Another type of a stab injury, and at the last, it's axillary injury with arterial and neurological injury. These are all the cases which are included in this study. This study was conducted in our department, 13 males and 9 females. Their age ranged from 12 to 50 years. All of them presented with non-traction injury. 7 of them were associated with vascular injuries. All of them were evaluated by nerve conduction, MRI, and CT angio. This table can show the diagram or the demographic data of our patients, their age, sex, site of injury, vascular associated injury, and time passed since the trauma and their presentation to us. All of these patients were treated surgically. Adhesolysis, direct repair, interposition graft, nerve transfers were applied according to the situation. Vascular repair using vein graft, synthetic graft were also done in associated vascular injury. A physiotherapeutic program was applied for all patients. Follow-up range 18 months. There were variable degrees of improvement in neurological outcome, but they are mostly satisfactory in these cases. This is our patient, the first patient, a stab wound here in the supraclavicular area. He had C5, C6 injury. There is failure of shoe production, the edge flexion, and as we can see here, this is atrophy in the shoulder. We explored this patient. This was our incision, and this is the intraoperative situation. We have a proximal end, a distal end, and the cut is here. After trimming and repair of the patient, of the teared part, they have the anterior division, the posterior division, the suprascapular nerve, and this is the site of our repair. This is 8 months after we did the surgery, and we have this result. This is video showing the improvement in abduction. Another case, this is a 25 years female. She was assaulted by a thief. She had a very ugly scar. She was transferred to the trauma hospital. She has severe bleeding in the trauma hospital. They control the bleeding, but still we have this sinus discharging pus from time to time. We decided to explore here. She has also failure of shoulder abduction and elbow flexion, and this is the operative photo. As we see here, this is the cut roots, and this is the remnant of the roots exiting from the foramen. We had to make 2 grafts. We did these 2 grafts from the remnant of the C5 and 6 to the upper roots. It's an early post-operative improvement showing some shoulder abduction and elbow flexion. Another case, we can see this 26 years female, she has an iatrogenic injury. As we can see here, there is 2 small scars in the supraclavicular area. This is 5 years ago, and this is 6 months ago. 5 years ago, she had a lymph node here in this place, and she would biopsied with no available pathology. Then we had this other scar in the 6 months ago, but the patient after this surgery had some weakness in shoulder abduction. As you can see here, her shoulder is unstable and she cannot do more abduction than this, except with the help of the other hand. This is the 2 scar. Intraoperatively, we found this a lot of adhesions around the nerve. Then after removal of some adhesions, and this is the lymph node, we removed the lymph node, and this is our post-operative pictures, a video. She regains the stability of his shoulder and the shoulder abduction with free movement.
هتجيب قدامك كده الاثنين زي قدام بعض، نزلي لتحت، ارفعي تاني لفوق، كمان لفوق، تمام.
Another case, a 50 years female with history of axillary mass, biopsy 3 months ago, followed by weakness, hypothesia, atrophy. Biopsy results non-conclusive. Investigations revealed axillary mass, brachial plexus injury, and vascular injury. This is a preoperative angiography showing the defect in the artery. We explored this patient. You have to imagine this is the axilla, this is the limb, and this is the shoulder. And the surgeon tried to biopsy this deep lesion through this corridor, passing through the arteries and nerves. So the result is an untouched lesion with a neurovascular injury. And this is the lesion, the dermoid tumor. This is an early postoperative video for the patient. Another video. She regains her function, especially the hand function, as you can see here. Also, the vascularity of her hand is markedly improved. In our experience, anatomical repair is preferred when possible for better outcome. However, nerve and muscle transfers may be applied according to the situation. Early interference and the management is very preferred, and as spontaneous recovery is not expected, especially in penetrating injuries. Vascular injuries should be expected and investigated to be managed at the same situation. Multidisciplinary approach for preoperative assessment, surgical correction, and postoperative rehabilitation and management program. The incidence of iatrogenic injury of brachial plexus in the axilla and in the supraclavicular region reflect the high importance of spreading awareness of the anatomy of the brachial plexus and its relation to the parts of this place. In conclusion, the key difference between traction and non-traction injury types of injury is a different mechanism which produce different pathology, neurological deficit, management strategies, and options for repair. Thank you, and I am so sorry for this technical problem.
Thank you. Hesham, please turn off your share screening option. Now we have a time for discussion. As per agenda, this is a 10 minutes for discussion. But if discussion is more, let's say, very interesting. We can extend it if there is interest for that. We have some, Hesham, please turn off your share option screen. We have some questions from the floor, but first of all, I will go through the all presentations, starting from the first one from Professor Mariana Sokolowski. Any comments from the panel for this presentation? So far, no comments, no suggestions. We can continue for next next talk of Professor Spinner, the evolving role of nerve biopsy. Any comment and discussion about this presentation? We have some comments and questions in the chat, but they are not related to the individual presentation. They are general comments and questions. We will display them shortly, but just now, I would like to ask if somebody would like to make a comment about related to the presentation of Professor Spinner.
I'll ask him a question.
Oh, please, Alan. Hey, hello. Yes.
If you're doing a biopsy, and I understand now you probably wouldn't be given the imaging technique and how good you really have gotten at this, but nevertheless, you're doing a biopsy and you find a paraneurioma. Do you go after the paraneurioma and try to resect it? Do you leave it alone? What do you do with it?
Yeah, so good question. So first of all, you know, I think our experience hasn't been validated. I think there are some other groups that still think you need to biopsy all perineuriomas. I think TJ Wilson's paper really showed that the ones with classic clinical features, including the one I showed, a 3-year, 5-year history in a young woman with progressive and characteristic enhancement patterns, I don't think you need to biopsy. I think that's what it is. Now, your question gets to the real meat is, what do you do? A lot of the patients I see, probably like you, have had chronic changes for almost even a decade. So it's not even 2 or 3 years. They're proximal. Some of the lesions are very lengthy. So I can see ones that are 20 centimeters long. So the first thing is the natural history is favorable as far as it's not a cancer, it doesn't turn into anything bad, and it doesn't seem to go from a perineal division to a tibial division. So for the most part, I would say most of these, with the lengthy, long lesions, chronicity-wise, can be treated with tendon transfers and not resected because they don't change into anything. I think if you probably try to resect it, many of the patients with partial loss, I would make worse. And then if I did nerve grafting, I'm doing a long graft proximally, it just doesn't make sense in the patient to me who has tendon transfer options. Now, is there an occasional patient that you might be able to do a nerve transfer, et cetera? The answer is there's always individual cases. So I just saw and treated a patient with a radial nerve problem that really was affecting the triceps branches only. Everything else was good. Even though he had symptoms for a long time, the radial nerve was actually doing fine, and you could always do standard wrist and finger tendon transfers. The lesion caused no triceps function. So I did a reverse ulnar fascicular transfer for triceps, okay, just like our colleagues in South America. So Alan, I don't know, you know, this is new. I don't think you have to biopsy them all. I think time will show that. I think there are atypical ones. The jury's still out. We need technology and experience. I don't have the answers to all of them, though.
Thank you for the thoughtful answer.
Thank you.
Bob,
I'll go back to Mariano. Mariano, thank you for showing what I've always kind of made mental minds about, is patients in America who are heavier and have an elevated BMI, boy, the shoulder results stink. And, it's not that we don't appreciate the work of our colleagues, but our patients are different. So thanks for giving us some p-values to sink our teeth in. No pun intended.
Thank you very much. Thank you very much. Thanks.
It's good to see you all.
Yes, absolutely. Hope to see you in present, all of you, in the next year, perhaps, or month. Hopefully.
Yes. Any other comment? Nice discussion. Welcome, Christian. You are on board, as I can hear, as I can see you. Any other comment, question for these two presentations? If not, next presentation is Professor Thomas Kretschmer from Austria about neurogenic thoracic outlet syndrome. Any other comment except this one, which Thomas already replied to Agmar Hanna about taking out first rib or pectoralis minor muscle. Thomas, can you comment on this?
The short answer would be no. I'm trying to see before surgery what the offender is or the offenders, and then would just remove what is impinging or narrowing or whatever, and I think the main mistake would be to not realize that all these patients can be different, and that I think the more imaging we will do and the more refined imaging will be, and the more we correlate the intraoperative findings with imaging, we will see that there are much more anatomical structures that can narrow the space for C8T1 and the inferior trunk. But if I look at my patients, how often did I have to remove the first rib? I don't see that I really had to. In the one patient that I skipped, we actually looked with the biportal approach if there was something else in the retropec minor space, but there wasn't. But there was also a psychosomatic component to that patient who had supraclavically real findings.
So I had emailed Thomas. I think his presentation was beautiful. I give him a lot of credit for producing some science underneath a difficult area. I think, the ones with true lower trunk findings, they have to have imaging abnormalities. I mean, if you're localizing it to the lower trunk, then resolution has gotten good enough that if you've ruled out a C8 spinal nerve posteriorly, there has to be something in the plexus. Now, I don't have the ultrasound capabilities here that you do, and I credit you. I wish I had the MRI experience. I'm just not seeing all those patients, but the few that I operate have MR abnormalities. So I credit you for that. And I would tell you, like I did in the chat, to keep correlating because it's important. And then wonder what happens with the patients who have symptoms who don't have any ultrasound findings. As far as the pec minor, I've really lost sleep about this because I think, like Alan Bellsberg, there are several groups in America who are widely doing this, and now even arthroscopically. And every time I do an infraclavicular plexus, I'm always noting how much fat there is under the pec minor. And now I buy that there may be some deep fascial scarring at the subclavius, like Hanno Malesi, like Deborah credited. He always would talk about that. I do have trouble with the pec minor because, I mean, the medial cord is so far away and there's so much fat there that I just don't know that I would routinely do that. And like Thomas, when I do it, I go for the scalenes, approximately like Dr. Klein taught me. Anyway, my 2 cents.
Thank you, Robert. Any other comment? we should move to the next presentation, past, present, and future in brachial plexus surgery. Professor Deborah Garozzo, any comment? How about robotics in brachial plexus surgery? Deborah, what is your opinion about this?
Well, I definitely have to say that I believe that we have to accept that there are some biological borders that we are not able to cross with surgery. And I think that probably we really have to consider resorting to technology and maybe robotics. So I think, yes, I believe that you're right when you mentioned that. I think that the future is related to the progress of technology. But we have to consider that, unfortunately, the patients that are affected by this kind of injuries are definitely a minority in the Western world. And most of them are, as I mentioned before, in low-income countries. Now, we know very well that research is something that focuses where there is money. So I think that, yes, the solution from the theoretical point of view is to try to resort to robotics. But on the other side, I wonder how much this is going to be feasible when we have such large cohorts of patients in sub-Saharan Africa or India, in countries where, I mean, they're burdened by remarkable financial difficulties. So, there is a discrepancy between what we wish theoretically and what we can do practically that we still have to sort out.
Thank you. Any other comment?
I think in the chat there was a question about how transcortical magnetic stimulation can favor the improvement of the outcome of brachial plexus surgery, and that was the question of Dr. Mariam Ghanem. So I'd like to give an explanation about that. So what I mentioned in my presentation is that the real reason why we're not able to get renervation of the hand is basically related to the cortical reorganization that you have after an extensive denervation of the brachial plexus. So what happens is that we know that neuroplasticity is also related to the fact that the motor cortex is not like a stable structure. There are changes. And what we can see, for instance, when we do a functional MRI, is that the area related to the cortex corresponding to the denervation of the plexus is actually going to be progressively reduced. And for instance, especially in young patients, sometimes you can see that you really have clinical evidence that the surrounding areas can, let's say, conquer the denervated cortex. So I think everybody has the impression that already had, the experience of patients telling doctor, I'm talking about total palsy with avulsions. It happens to me that if I touch my face, I can feel like I'm touching my hand. And this is related to the cortical reorganization. So the idea behind transcranial magnetic stimulation is to try to maintain alive that part of the motor cortex. And this seems to be related to a more favorable outcome. They've tried that, for instance, in patients that presented stroke, and they have seen that with physiotherapy, when these patients are submitted to transcranial magnetic stimulation, the performances are actually better. Now, of course, we have to consider that in stroke, we have a different situation than patients with avulsive injuries, because in those patients, we do not have a loss of anatomical continuity like in our patients. But again, as I said, this seems to be an initial step and it seems to be promising. So we have to see.
Thank you. Any further comments?
Lucas?
Yes. Yes, Maria.
I want to make a question maybe to all the panelists. I congratulate Deborah for her talk about past, present, and future. What about present? And let me just combine our situation regarding COVID and long-term illness in COVID, that they sometimes are followed by brachial plexus injury, not traction, of course. So I want to know if someone has any type of experience. I saw some patients with this type of affection. I did never operate on them, and just to know if someone has the same feeling about this entity, or someone has a surgical experience about that.
Dariano, I don't have experience specifically in this kind of situation, but what we have to consider is that we already have seen that there have been cases of patients with immune-based neuropathies, like for instance, Personage-Turner, where we have started to do nerve transfers and we saw favorable results. So personally, as I say, I don't have an experience in that. I have experience with patients with Personage-Turner that I treated with nerve transfers and that presented functional recovery. So I believe that maybe this is what we might attempt in these patients as well. And specifically, when we talk about Personage-Turner, what I try to do is not to perform the nerve transfer interrupting the continuity of the nerve. Like, I mean, normally when we do, for instance, spinal accessory to suprascapular nerve transfer, right? We completely transect the nerve from when it's branching off from the upper trunk, and then we co-opt it with the spinal accessory. Okay, so what I try to do in patients with the Personage-Turner, because we know that there is a potential for spontaneous recovery, is that I just do a supercharge. So I add the spinal accessory to the suprascapular nerve, but I try to maintain its continuity still with the upper trunk. And the same thing, for instance, for the axillary nerve. In those cases, I mean, not that I have done all those many cases, you know, this is occasional, but I mean, using the nerve for the latissimus dorsi, the thoracodorsal nerve, to the axillary, and again, without the loss of continuity, but just adding the thoracodorsal nerve to the axillary nerve. So in that way, I think that I don't jeopardize any possibility of spontaneous recovery in case this, you know, takes longer. And at the same time, I supercharge. I do hope I made myself clear.
Yes, absolutely. Yes.
Okay. So this is what I think might be a possibility of treatment for these patients. This selective supercharge of with nerve transfers in these patients. But mostly, I have seen that these the patients with this kind of sequelae. I had a couple of cases that were referred to me for neurological evaluation, and then, to be honest, I lost them. They had problems in the lower limbs, not the brachial plexus.
Okay, thank you. Someone
I have one more question for the board.
Yes.
About the future of the brachial plexus surgery, Professor Deborah.
Yeah.
What about using of stem cells and nerve growth factors, and can they add much more improvement in our patients or not?
Okay, so this is usually a question that I receive from patients. Every time I have a patient with multiple avulsions of brachial plexus, one of the questions I receive is, what about stem cells? Now, I have to see, again, I don't have personal experience, but I don't think that really this is an option that we have nowadays. There are not studies which have been published in the literature that I would consider that are reliable. And I'm sorry to say that, but most of the patients that have been treated with the stem cell therapies, and not only for this kind of pathology, are just in private institutions, sometimes not even officially recognized by the state. And in my opinion, this is just a big commercial thing, and it is done at the expenses of the patients. But I don't think right now we have elements in our hands to say that this is something which is consistent with the possibility of providing a better outcome. as I said before, based on my experience, I think that we have to accept that we have biological limits. I think the only way we have, if we want to go on doing surgery on total pulses and trying to boost the outcome, and this is why we neurosurgeons are important, is really to try to find a way to work on cortical reorganization and enhance neuroplasticity. And this should be probably combined with the option Lucas mentioned. Technology should help us to provide these patients with, device and help them. So probably, combining, trying to boost neuroplasticity and at the same time add technology. But stem cells, I don't know the opinion of my other colleagues here, but I don't get the impression that this is what is going to help us.
Thank you, Deborah. Christopher Winfrey would like to raise a hand to give a comment about COVID-19 and brachial plexus lesions. Chris, are you here? Christopher. He just sent me a text message that he would like to make a comment and he is in, but I cannot see him now. He can make a comment later on. Any other comments? He's now sending me a message that he's speaking, but I cannot hear. Maybe somebody can hear. Nasser, is he online? Christopher.
Lucas, can you say his name again, please?
Yeah, I cannot see Christopher Winfrey, but
Christopher, I couldn't see him as well.
He may not have signed in using the speaker link. That's what he needs to do. He needs to sign in.
I was looking among attendees and among panelists. I couldn't see him. I just looked few minutes ago, but let me have another look now.
Maybe he's using only speaker's link. Just he's trying to tell something, but he's not able. Okay, Thomas.
I've seen him among the attendees. There are a couple of us who had all the same problem. We did not have a speaker entry, but I've seen him amongst the attendees. He's in the attendee list.
Thomas, the Zoom link was sent to you 3 times.
I know.
Maybe it went to spam. That is the problem. We're always sending emails saying, please do confirmation. If you received or you didn't receive, we are asking sometimes for cellular phones in case of emergency. But I think 2 of our speakers didn't receive the link. That is problem of email. If you put institutional email, sometimes our emails go to the spam. Anyhow, we can, we
How
have
about
a
this?
Here it is.
Okay,
you're right. It was the speaker link. I logged in with the attendee link. I apologize.
Okay.
Thank you.
Mariano, I had an answer to your COVID peripheral neuropathy question. A couple of months ago, we published a case series of patients with severe COVID infection, ICU stays, who have long segment T2 hyperintensities in a variety of different nerves, sciatic nerves, peroneal nerves, brachial plexus. So it's a very real phenomenon. As of yet, we do not have pathology. We have not biopsied these patients, but we've seen a lot of them, and some of them are starting to recover. So it's a very real phenomenon. We have an experience with it, but I have not treated them surgically.
Thank you very much for your answer. I know some people that are that has not, it's not my case, of course, but that has some experience opening the epineuron in those cases that you just quote. And my question was focalized to that question. In fact, is it worthwhile to go and operate them? I feel we shouldn't, but maybe we can, as a panelist, co-expert analyze this topic, which is of actual present.
I would say if the ultrasound or neurography shows nerve compression, then it's worth decompressing the nerve. But in the absence of that, I would argue against surgery routinely.
Okay.
Thomas.
Thomas?
Thomas. Internet. Thomas.
I just want to ask about how many patients Christopher saw, and if they present, because I've never seen a patient like that. Is it then the presentation similar to a Parsonage Turner, severe pain and loss of function, or?
In our experience, these patients are comatose for up to a month or two at a time. And as they're emerging from their comas, we realize they have deficits. So there was no good description of a prodrome. These patients are in coma for a prolonged period of time. And so we pretty much ruled out positioning injuries in most cases because it's not consistent with a compressive mechanism. They just show up with deficits and we get these imaging studies and the nerves are widely affected.
So you just realize it when they recover?
Exactly.
Okay, thank you.
Yes, I just have message from Professor Hisham Basyouni from Germany. He'd like to say a comment. Hisham, can you hear me?
Yes.
I can hear. Thank you very much for your invitation and good day to all. I'm just enjoying the discussion. I have no special comment. I can support what Professor De Burros just said about the stem cells. It's also my impression it's a very big commercial with no effect for or no benefit for the patients. I completely agree with you on this topic.
Thanks. I think this is something that we really should insist on, because I'm afraid that we have to say that, especially with internet, that has become one of the main tools, or maybe the exclusive tools that use in order to understand what kind of treatment they are supposed to do. And I've seen so many advertisements of private clinics in USA, in Ukraine, in countries like Thailand or China, advertising stem cell therapy. And they are really, I mean, this is really exploiting people sufferings, because these people travel there full of hopes. And of course, they spend a lot of money also because, like, you know, these are not treatments which are officially recognized. But at that point, when you are desperate, you try to do everything. And I mean, I happen to have, for instance, and I say that to Robert especially, I even read something about a doctor working in Mayo Clinic and promising results after spinal cord injury. And I know because a lot of patients from the Middle East apparently want to go there, also considering that the guy seems to be probably of, you know, Arabic origin. I mean, I don't want to give the names, but I'm sure that you know who I'm talking about, right, Robert?
I do. So
there was a
different kettle of fish. So that's spinal cord injury. I think Alan knows the person because he's a partially Hopkins person also. You know, it was a case report that got picked up. Anyway, no comment. I mean, it's one patient that now there are some studies being done. I think it's like anything else, buyer beware. I agree with your earlier comments. I mean, we see a lot of patients who've sold their houses to pay for stem cells in another country.
And this is why I say that actually we should do something, because I mean, if the scientific community has the possibility to demonstrate clearly that there is no favorable outcome with this kind of treatment, we should try to people know that this is just a financial speculation by people that have no scruples. And to be honest, especially if somebody under the umbrella of prestigious facilities like yours also indulge in this kind of situation, I think, you know, this is something that should be brought to notice to people.
Well, I think it, the case report is a case report. They're not promising anything here. It's not me, but there is a meta-analysis coming out on stem cells. It's actually very well done. I was just reviewing it from another group where there is some scientific basis on the literature, and they do a nice review of the handful of cases that have been done for brachial plexus clinically. Like I say, I'm not an advocate at all, and I still think that it's caveat emptor. So buyer beware.
Thank you. We have to continue with the program since Professor Belsberg have to go to the OR soon. I would like to invite our host, Professor El-Ghandour, to continue to lead the second session of the program, and we'll have enough time for discussion after the second session.
Thank you, Lucas. Actually, the discussion was very interesting, and I think the topics for the next session are very interesting too. Now we move to our next speaker, Professor Alan Belsberg. He's Professor of Neurosurgery at Johns Hopkins University, United States of America. Is going to speak about peripheral nerve repair in the lower extremity, novel approaches.
Okay, so hopefully that's showing up well. You can see the slides.
Yes, perfect.
Good. So first of all, I want to thank Lucas and Nasser for putting this together. You've done a wonderful job and moving the technology along. You've been doing great with that. It's also, of course, wonderful to see all of my colleagues who've been presenting. It's great to see you all. It's a thrill, as a matter of fact. It's been way too long, so I really do appreciate seeing you all. What I'm going to do in this about next 15 minutes, I'm going to present 3 cases to you. And the 3 cases I'm using are to illustrate some of the concepts that we're thinking about in terms of nerve repair, and specifically nerve repair in the lower extremity. So things do change over time. Here's the hospital when I first came as a fellow, just kidding, but there it is, Johns Hopkins way back when, and here it is today. So things do change over time, but there are some historical things that become very important. As we are all neurosurgeons, I go back to Harvey Cushing. Most people think of Harvey Cushing as a brain surgeon, but Harvey Cushing was very much a peripheral nerve surgeon as well. And I'll try to bring that out for you. One of the interesting things that I'll ask right up front is when Harvey Cushing finished his training and came on faculty at Johns Hopkins in 1901, what do you think his salary was? So just an interesting little tidbit. I'll tell you, it was $100. And the question was, is it $100 a day? Was he making $100 a week or $100 a month? And that was in 1901. We're talking American dollars. And because we're not sitting together, I can't hear any responses of what you're thinking. But I will tell you, he was paid $100 a year. That was his salary back in 1901 when he became a neurosurgeon at Johns Hopkins. So moving into the lower extremity, I've become interested in nerve repair in the lower extremity for a couple of reasons. The first one is because we got interested in this concept of transverse myelitis and acute flaccid myelitis. And you start to see lower extremity injury as much as upper extremity injury. So we did publish way back when on transverse myelitis some 10, 12 years ago now. We got interested. We started to report doing nerve transfer surgery for transverse myelitis. And I think in retrospect, the paper and actually the case report that I put out on this may have actually been more of an acute flaccid myelitis rather than transverse myelitis, be that as it may. And then also we became interested in doing nerve transfers for specifically in the lower extremity. So this was one of our first ones that we put out over here, where we did an obturator transfer for femoral nerve repair. So obturator to femoral to try to get back some function. So we've been thinking about it and playing with it for at least 10 to 15 years now and making some progress. So I'm going to present this one to you. This is an acute, and I hope this all shows up to you. Let me just move that. Acute flaccid myelitis or acute flaccid paralysis. And again, this is a fairly novel diagnosis these days. Suffice it to say, this really is modern day polio. It seems to come on about every 2 years. We're seeing cases. It's a lower motor neuron disease. It affects the anterior horn cell, much like polio does. And it's an overlap with the same virus that does cause polio. And it results in classic polio type presentation with loss of function. So what I'm going to show you is a very novel approach that we've taken in terms of trying to get back some function in the lower extremity. And this relates specifically to acute flaccid myelitis, where in this particular case that I'm going to present to you that we've recently published, this is a child who has no femoral nerve function, no obturator function, but had good preservation of their sciatic nerve. So tibial and peroneal nerve functioning well, but a complete loss of femoral, so no quads. And I want to acknowledge Amy Moore on this publication. Amy was one of the people who really thought this through, developed the concept. And I'm going to show you the child that we did at Hopkins and reported on in the literature. So what we're going to do here is we're going to transfer a fascicle from the sciatic nerve, and specifically the tibial nerve. We're going to take a tibial nerve fascicle and transfer that to the femoral nerve. Okay, so that's the concept, and this is what it looked like in the operating room. We start in the supine position. We're going to expose the femoral nerve, its various branches, lay them all out, and then we're going to lift up the legs, and we're going to expose the sciatic nerve. We're going to do an internal neurolysis, separate out tibial, and then we're going to bring one of the femoral nerve branches down through the leg and do a direct repair of a tibial nerve transfer into the femoral nerve. This is what it looks like in terms of a schematic, and this I attribute to wonderful work by Ian Suk in our at Hopkins, who does our illustrations. So again, we start with the anterior approach, we go to the posterior approach, and then literally we're going to go right through the leg, bringing the femoral nerve from the anterior to the posterior, and then do a typical fascicular transfer into that branch. So we've had some mixed results with it. We've been a little late on some of the kids getting in there, and I think that's why some of the results are not as good as we had hoped. A little too soon still to tell you exactly how this is working, but I think it is working, at least in a couple of the kids that we've been doing it in. So I give acknowledgement to Deborah, who tried to give us some historical, and I'll say that every time we think we're doing something for the first time, we're usually wrong. And if you go to the literature, usually for us, it's the Germans have done it long before we did. But in this case, I'll go right back to Harvey Cushing and say he wasn't just a brain surgeon, he was very much a peripheral nerve surgeon. So these are some of his reports on doing nerve transfers back in the early 1900s, 1903. But as we go through the records at Hopkins and we look at some of the cases that Harvey Cushing did, it's much more of a peripheral nerve surgeon than one would think. And we recently published this paper, and it's basically Harvey Cushing treating polio patients doing typical peripheral nerve transfers. He did not do fascicular transfers like the Oberlin, but he was doing intraplexal, extraplexal, upper extremity, and lower extremity. And he was doing multiple types of nerve transfers. In this particular case of a polio in a child, he did multiple nerve transfers in this child, both upper and lower extremity. So it goes back to 1904. Okay, next case, something that always has bothered me, neuromas in continuity. How do you figure them out? Dave Klein, talked about this for many years. You're faced with two neuromas in continuity. One is showing spontaneous regeneration, one's showing swirling. This one needed to be resected, this one didn't. And Dave Klein gave us intraoperative neurophysiology, nerve conduction studies looking at compound nerve action potentials to try to sort that through. Follow-up paper of his showing nerve conductions where you can get a compound action potential here, but not over here. We've never been able to reproduce this. And I struggled at Hopkins for many years trying to reproduce his ability to do the conduction studies. And we've changed the way we do them. I won't say an advancement, I'll say a change from the way that Klein had described it. We went into the laboratory and tried to figure out what we were doing wrong. And it turns out the way we were doing our conductions by lifting the nerve off was what was messing us up. we started to look at various bridging, and I'll show you what that looks like. And as we would bridge and change the way the electricity flows, we were able to much better reproduce compound nerve action potentials. So we now use a bridge between our stimulating and recording electrode. And here we are in the operating room doing it. Again, a stimulating and recording electrode with a saline sponge serving as our bridge. And we're able to do much better in terms of getting compound nerve action potentials. We've redefined the way we do our electrodes. This is a new type of electrode we've developed. And now we can produce fairly consistent compound nerve action potentials and use this in the operating room. So let's see what that looks like. And again, neuroman continuity, redefining the way we're going to do it. 20-year-old with a gunshot to the right lower extremity, gunshots. Deborah, we don't need to worry about wars in Baltimore. Baltimore itself is a war zone, so we see gunshots all the time. Complete perineal nerve palsy, surgical exploration at 5 months. And we did intraoperative nerve conductions. So here we are, we've got proximal distal. This is the common perineal nerve, tibial nerve over here. You'll see a close-up shortly, and there's a neuroman continuity. So here's the neuroman continuity. Tibial nerve looks pristine. This is the lateral sural, common perineal coming down, and the neuroma did not conduct. So that's going to be resected. And when we resect it, we're left, as you know, with a fairly sizable gap. And the question is, what do you do with gaps in the lower extremity? We always say that these tend not to do well with grafts. Can we do a direct end-to-end repair? What can we do to improve our end-to-end repair versus using putting in grafts? So here you see the same patient. We've resected the neuroman continuity, and we have an end-to-end repair, direct end-to-end repair, no graft. But we've taken out a fair chunk of that nerve. And the question comes, and here's the glue on top, how did we get a direct end-to-end repair without tension in that lower extremity? And the answer is the knee is flexed. So we know, and this has been around for a while, if you flex the knee, you can get an end-to-end repair. The problem is now you flex the knee and you have to gradually re-extend the knee. So I've been doing this for a number of years, and I've been putting patients in braces, and we try to then gradually re-extend the knee and grow the nerve. And when you can do it, those patients do well, and they do much better than what I've been able to do with nerve grafting. On the other hand, some of these patients take their brace off and have a shower and re-extend their knee. And of course, it pulls apart and we get into trouble. Others don't like the feel of the brace. So that's a mixed bag. Sometimes it works, sometimes it doesn't. This is an external fixator, and people use this to grow bones and do various things for bad fractures. And so now what I've done is I've gone to using the external fixator with the help of my orthopedic colleagues. And here's that same patient, end-to-end repair, lots of laxity, no tension, knee is flexed, and an external fixator has been placed. And we will gradually re-extend that knee over time. This patient did very well, but we did it in a controlled fashion with the external fixator and our ability to control that gradual extension. Okay. Third case, 17-year-old male suffered a propeller motorboat accident in Texas. The motorboat actually backed up over him while he was swimming behind the motorboat. Suffered a very severe propeller injury to the lower extremities and had a Sunderland grade 5 sciatic nerve injury. In Texas, they repaired the vasculature, did a beautiful job of repairing the vasculature, and tried to bring together the nerve. But there was a huge gap. They weren't going to be able to do it. So they sent the patient up to me at Hopkins and said, is there anything you can do? When we had a look at this, the vascular repair was perfect. He had a great vasculature to the lower extremity, but in fact, his sciatic nerve was a mess, very proximal injury right at the buttock crease. And we were left with a 7-centimeter gap. And no matter how much I mobilized the nerve, including flexing the knee, mobilizing it proximal and distal, I couldn't get anything less than a 7-centimeter gap. I'm at the buttock crease, and we knew that we would need at least 6 to 8 sural nerves to do 7-centimeter grafts. We're at the very proximal part of the butt, or at the thigh. That patient's not going to do well. And the question was, what else could we do to try to improve the chance of him getting some sort of functional recovery? So here's the nerve. Patient's prone, proximal, distal. This is the buttock crease right here. You're on the buttock, very proximal thigh. Here's his sciatic nerve. And what you see is a nice overlap. In fact, when you cut here, and we get the very healthy nerve, if you cut here and cut here, we're going to do a direct end-to-end tension-free repair. And the question is, how did we ever get that much overlap? I told you, in fact, there was a 7-centimeter gap. And now in this picture, I'm showing you not only no gap, beautiful ability to do a no tension end-to-end repair. What I want you to note is the date of this photograph, July 30th, 2020. This past summer, July 30th is when this occurred. So how did we get to this position? Here we are in the operating room, my orthopedic colleague working with me, and he's got what's called a jiggly saw in his hand. And neurosurgeons who've been around for a while know exactly what a jiggly saw is. We are going to remove 7 centimeters of his femur and shorten his leg. So here it is. We're putting the rod across the femur, and that's after we've removed this piece of bone. We're putting a rod right across, and we're going to shorten his leg. This is the rod going in. Here's your rod going down the femur. So in order to achieve this, I basically shortened his leg 7 centimeters. Proximal, distal, there's the rod, here's the proximal end of the femur, distal end of the femur, a 7-centimeter gap with just a rod.
Yeah. All right, I'm done.
So what we're doing is we're going to shorten it by 7 centimeters, lock it in position. His leg is going to be 7 centimeters shorter, but that allowed a perfect end-to-end tension-free repair. Glue on top. This is us bringing the glutes back over top. So we had a nice end-to-end tension-free repair, but he's now 7 centimeters shorter. Here's his right leg, and you can actually see right leg. He is, in fact, his leg is 7 centimeters shorter than this one. So what we can do is over time regrow that leg. And that's what we did. We put a growing rod in. And while we were waiting for nerve regeneration, we also were growing his leg back at about 1 millimeter every other day. So now I want you again to very carefully think about this. July 30th was this surgery. We are going to grow his leg about 1 millimeter a day. So it's going to take a while, but another 70 days for us to regrow back to his original length. And the question becomes, when should we expect any kind of recovery in his most proximal muscle here in the gastroc on that tibial nerve? This is a 6'1" patient. There's the repair of the actual tension-free sciatic nerve. It's got to grow all the way back down his thigh, into that proximal part, and all the way down to his gastrocs. Plus, we're adding an extra 7 centimeters over time during this growth period. So start thinking about what you're going to tell the patient and his parents, because we were saying it's about 1.5 feet. So that's 1.5 years, at least another month for our nerve repair site. And he's getting an extra 7 centimeters of growth over time. So we'll add another month or 2 for that. So we said the earliest we're going to see anything is 1.5 years to 2 years. And we're really hoping for something. July 30th. This is a video of the patient, March the 28th, 8 months post-op. Right leg was where he had the injury. And we're starting to see plantar flexion. Now, this was sent to me from Texas, and I said, I don't believe you. I think what you're doing is probably moving something up here, and that's why the foot's moving. So I said, go on your stomach and hang your leg over, and let me see it that way. So he's now prone. Here's his foot. The right side is the side of the injury, hanging off the bed.
Right.
And you're seeing some plantar flexion. And again, think of this. This patient is 8 months post-op, a sciatic nerve repair, very proximal thigh, and I regrew his leg 7 centimeters during that time. So start thinking about how to explain it, because I'm going to want some answers from people.
Okay, try it.
Okay, finally, a perineal nerve injury after proximal injury that we see commonly with hip surgery, the stretch injury. Patients will get a grade 3 Sunderland injury. They do show spontaneous regeneration. You can follow it with the Tenell's sign. The problem is, by the time that Tenell's gets down past the fibular head into the gastroc, it's been 1.5 years, 2 years, 2.5 years. And although they do get some sensation back, they don't tend to get motor. And that's probably because the muscles are no longer there. What do you do with that patient? Well, we have decided what we're doing with those patients. We have a new approach now for getting back function in that perineal nerve after that very proximal stretch injury. But unfortunately, I am out of time, so I can't tell you about that. That'll have to wait to the next session. So thank you very much for allowing me to share some of this with you. And I look forward to any questions you may have.
Thank you very much, Alan, for this great talk and for these novel approaches and for this excellent illustration. Actually, I enjoyed your talk as well as all of us. And I think as we usually do, we take questions at the end of the session. And so now we proceed to our next speaker, Professor Christian Hennen from Germany. He is going to speak about retroperitoneal tumors, a tailored approach.
So is it? So first of all, thank you very much for the invitation, and of course, congratulations for this really, really fantastic program. And I'm happy to be part of it. So I will give a talk about the lumbosacral plexus and its tumors. And this project has partially been founded by our university here in Germany, and the talk will be divided in 2 parts. First is anatomy, and the second is surgery. So before we decided to have work on the retroperitoneal tumors, we were asking ourselves a lot of times, especially with the extended tumors, how to access them, how to get there, and maybe that the way to access it we did before was not appropriate, since there were some hints by other colleagues, for example, by the group of Robert Spinner, to have not a monoportal but a biportal approach. So we first went into anatomy, and
sorry, can you extend your screen, please? Can you make a slide? Yes, perfect. Yeah.
Okay, I'm sorry. So we went into anatomy, and we were fortunate to have fresh frozen cadavers, because they are very close to surgical reality. So we really could dig into this and have the dissections. And the findings that we had were super interesting, because we could see that the distribution of, I'm sorry, I think I chose the distribution of the contribution of the spinal nerves differed significantly. So these are just some images of our work. And for example, we found one plexus that we had a complete separation between a lumbar and the sacral plexus. So this was put together, and we had this huge variety that has also already been described before elsewhere with the nerves. I'm sorry, I need to check if I put the right. See, okay. So what we then did was to change our way to assess the tumors, and I'm sorry. Okay. So the main question that we had was how to access not the circumscribed and not the smaller tumors, but how to access some tumor like this that begins intraspinally, goes to the pelvis and gets out on the gluteal level. So it's obvious to see that this cannot be assessed in an appropriate way by one axis only. And what we were starting to think is how to put this into, into work, and how to get clear for ourselves for the surgical strategy to come up with a proper treatment concept in a surgical way. I mean, we all know that the retroperitoneal space is, well, you can find rarely tumors in it, especially this is for the benign one, and this is also for the sarcomas. And of course, every single tumor entity requires different way to treat. And something that is, at least for us, was when we began to operate on them, was clear that, of course, we are not abdominal surgeons. So this is something that maybe or that will need interdisciplinary approach. So this was mainly done with our abdominal surgeons. And the questions that we put to the beginning of everything was always to find out what we would expect, how radical we can get. Of course, and this is, I think this is a crucial point in tumor surgery, and in my opinion, this accounts also for malignant tumors or MPNST, is that the question of function sparing has gained more and more importance over the last years. And of course, what does the patient need and what does the patient want? And by that, combining the access, the surgical ports to get the best result for the patients and to preserve function and to preserve, of course, the adjacent anatomic structures. We treated 12 patients. The study was designed in a retrospective way. You can see the epidemiology. And you can see that this is, I think this is important, that all of them had pain, and most of them already showed deficits. And the signs of infiltration in the surrounding tissues was present in, as you can see, in 4 of them. So this is hinting towards malignancy. In terms of histopathology, we had 1 MPNST, 1 non-origin sarcoma, so nobody could tell us where it came from. And the further histology you can see here. And the surgical goal in all the patients was function sparing, and in cases possible to remove as much tumor as we could get. We didn't encounter a lot of complications, and this is in contrast to literature on these large tumors. They report huge complication rates, up to 30%. We had 1 temporary postoperative L5 motor weakness in a benign tumor, a patient that was operated on before elsewhere. So what were we looking for? So we divided, and this is beautiful drawing is done by Thomas. You can find it in our publication. We defined the anatomic landmarks that were coming from surgery, the most relevant to us. So this is the lateral and medial psoas bordal, the inguinal ligament, promontorium, and the piriformis muscle, to define where the tumors grow along and which route they grew on, to choose the proper axes. So if you can have a look at these pictures, you see I showed you this one before, and this one is another lady. She was operated elsewhere before with this tumor along the sciatic nerve. And it's very close to the infrapiriform foramen. So what to do with it? What do we want to do? Both of them had pain as the major clinical appearance. And it is obvious to see that this tumor cannot be treated in a surgical way in the same way that this tumor can be treated. But the goal of both treatments was to have it removed without loss of function. So we needed to come up with an idea how to access this tumor and how to access this tumor. And the histopathology showed completely different entities. This tumor was done by a transperitoneal approach, and this was a combined one. So we started with transperitoneal and then turned the patient around, and in the same session did a dorsal approach to remove transglutally, to remove this part of the tumor. The sarcoma mainly affected the tibial part. So this was already lost before surgery, but for the rest we could preserve function. The lady was operated on was one of the first ones, so it's 9 years ago. And after surgery, she received chemotherapy and is still alive and doing well with of course, with the existing loss of tibial function on the left side. So what we learned was that the anatomical landmarks that we set in anatomy, in the dissections, we could translate them into MR, and from MR back to our patients. So we found this way to assess tumors and to plan our surgeries very helpful. And as I showed you, there were, aside from the L5 weakness temporary after the surgery, we didn't encounter any complications. And in terms of radical resection, because this is always a huge issue, especially if you deal with the sarcoma surgeons, our findings show, and of course our number is very limited and very small, our numbers show that the function sparing resection is something that is useful and that is sensitive, and that that changed our way to approach these tumors a lot. So we opt for individually tailored strategies. This has been published, and this is once again an illustration of how tumors can extend and which axis we will choose for, and the combination of the axes. So in conclusion, the anatomical landmarks are crucial to define in first term, and this will make you decide over the best way for the patient to be operated on. I want to thank the team. Thomas is part of it, colleagues of my former hospital in Oldenburg are parts of it, and these are the guys from the anatomy in the Netherlands, and thank you very much.
Thank you very much, Professor Christian, for this interesting presentation. And our next speaker is Professor Christopher Winfrey. Is going to speak about peripheral nerve stimulation for chronic neuropathic pain.
All right, let me get set up here. Thank you, Nasser and Lucas, for the kind invitation. And it's great to see everybody again and some new faces. I hope and look forward to getting together in person shortly. I added this note here: if you want new ideas, read old books. If you want old ideas, read new books, to answer Dr. Bellsberg's comment about getting new ideas from the greats of our, the godfathers of our profession. And I think it's a really great saying that applies. So we're going to talk about peripheral nerve stimulation today, and I'm going to argue that there's no more exciting time to be a peripheral nerve surgeon than now, and there's no better time to be someone to do peripheral nerve stimulation. This is really the heyday of this field, and we're seeing a transformation of the field right now. Peripheral nerve stimulation is electrical neuromodulation of the peripheral nerves, pretty self-explanatory. And this is a type of neuromodulation that started it all back in 1967. The very first published forms of neuromodulation were on the peripheral nerves, including the trigeminal nerve, the median nerve, ulnar nerve, and other nerves way back in the 1960s, before some of us were even born. And about 12 years later, the first multi-contact peripheral nerve stimulators connected to implantable pulse generators were developed, really in much the same structure that we see today. And it's other than the programming, which has changed a lot, the actual physical structure hasn't changed all that much. And so for a number of years, peripheral nerve stimulation was accomplished by largely peripheral nerve surgeons surgically exploring the nerves, placing electrodes in one form or another on the nerves, externalizing the wires, performing intraoperative and postoperative testing, and then internalizing the systems with buried implantable pulse generators, often repurposing spinal cord stimulator or even homemade electrodes and extension wires in very cumbersome and bulky systems, which were inconvenient for the surgeons and inconvenient for patients as well. But they largely worked, and there were a number of studies over the 80s and 90s and 2000s that demonstrated the effectiveness of peripheral nerve stimulation in a variety of different parts of the body for a variety of different pathologies, including complex regional pain syndrome and other nerve injury types of pain, giving about 50, 60, even 70% rates of effectiveness. So it was a viable treatment option. So the question is, why even use peripheral nerve stimulation when you have other types of neurostimulation? And the issue is, if we use the case of a patient with an ulnar neuralgia, where pain in the ulnar nerve distribution, we can put a spinal cord stimulator in that patient and basically blast the entire extremity with stimulation paresthesias, tingling, electrical sensations, which can help the pain. But a lot of patients find those extra sensations in parts of the body unaffected by the pain. They find those stimulation sensations annoying. And so ideally, you would like to focus the stimulation just in the painful part of the body. So if the pain is in a peripheral nerve distribution, then a peripheral nerve stimulator is going to be the best way to do that, rather than, say, a spinal cord stimulator. Similarly, when a patient has inguinal distribution pain from, say, a post-herniorrhaphy pain syndrome, a spinal cord stimulator will likely bathe the entire leg in stimulation, whereas a peripheral nerve stimulator will focus the stimulation only where it's needed. And patients tend to prefer that. Well, if it's so effective and so great a technique, why didn't it really catch on? Why weren't more people doing this in the 2000s and 2010s? Well, it turns out that the old types of peripheral nerve stimulators really required peripheral nerve surgery expertise. You had to dissect out the nerves. And, a lot of people couldn't do that. In the United States, at least, these procedures were often denied by insurance companies. They were seen as experimental and not really worthy of payment by the insurance companies. In other cases, the procedures were improved, but they didn't reimburse enough. And in fact, hospitals would often lose money putting these implants into patients because there simply wasn't the money available to put them in. We also had limited hardware options. There was not a lot of innovation producing new types of peripheral nerve stimulators. We were largely using repurposed spinal cord stimulator hardware, which is really suboptimal for the peripheral nervous system. And as a result, we had high complication rates. The batteries were too big, the extension wires were not suitable across joints and limbs, and these things would break and they would move and they would scar up nerves, and patients had a really hard time with them. Also, in 2015, the development of high-frequency spinal cord stimulation allowed patients to have stimulation not be perceptible. So the whole need to focus the stimulation in the painful area was no longer necessary. So we could use a spinal cord stimulator to treat pain in one finger without worrying about having to focus the stimulation because they couldn't feel the paresthesias anymore. Nevertheless, there was still a population of patients that could potentially benefit from peripheral nerve stimulation. Patients with extensive fusion masses where you really did not want to go into the spine to place a stimulator. or patients who had craniofacial pain, where you couldn't reliably reach those painful areas with a spinal stimulator. So over time, peripheral nerve stimulation did find its place. For the past 20 or more years, we've been placing trigeminal branch stimulator electrodes, again, using repurposed spinal cord stimulator hardware, but doing it quite successfully. And patients can do really nicely with this modality for facial pain. We're utilizing the tonic stimulation, the kind that patients can feel, and we're using the other high frequency types of stimulation with success. And it's really been a nice way to treat facial pain. Similarly, with occipital neuralgia pain, or even some of the headache disorders, migraines, cluster headaches, occipital nerve stimulation can be a really nice treatment for that. We published guidelines on this a few years back to help clarify the use of this device and provide an evidence base. More recently, industry has been getting involved, producing new custom designed, purpose-driven electrodes that are not repurposed from the spinal cord, but designed specifically for peripheral nerves. There's a fairly new system on them, not on the market yet, but in development, where there's cuff electrodes and using high frequency stimulation to produce nerve blockade to treat post-amputation pain. And this device has been in clinical trials recently. A lot of you may know about vagal nerve stimulation, which again is a custom designed cuff electrode with a dedicated system just for vagal nerve stimulation. And this has shown some success in treating seizures, depression, and even some cognitive disorders, disorders of memory like Alzheimer's disease. One could devote their entire career to just doing vagal nerve stimulation cases. And it's a really, really neat tool in functional neurosurgery. And a lot of you may already be familiar with it. In the late 2000s and early 2010s, some of us started utilizing our ultrasound technology to optimize peripheral nerve stimulation. And what this did is this made peripheral nerve stimulation no longer an open surgical procedure that required a peripheral nerve surgeon. This now opened the doors to non-surgical pain specialists utilizing and adopting this technique to help a dramatic increase in the number of patients. So we published on this, as did other groups, a minimally invasive, percutaneous, ultrasound guided, safe way of accessing the deep peripheral nerves near blood vessels in a way that minimized the risk of injury. And here's a video of us doing that just to illustrate real quickly. You have the patient in the operating room and placing the electrodes. You know what, the video is not working, it's okay. But basically what we're doing is a very easy, quick way of placing the electrodes and getting the patient to respond in a way that is very helpful. And again, this doesn't require any open surgery and no surgical exploration of the nerves whatsoever. Not long after that, industry again, working with physicians, developed dedicated peripheral nerve stimulator systems with timed electrodes to limit the risk of migration, devices that no longer required an implantable pulse generator. It's the IPGs that really plague patients and doctors. These are the ones, that's the thing that is uncomfortable for patients. That's where the infections occur in patients, and that's really the problem area. And these new systems have obviated the need for an implantable device. The device is a single wire placed under the skin with an external battery that the patient can put on. They can take it off when they don't want to use it. They can put it on when they need it. Once we had this safe, easy system, we started exploring other types of modalities for the peripheral nerve stimulator system. Historically, the electrodes are placed along mixed motor and sensory nerves to treat the sensory or pain component. It turns out the motor system is very important in the modulation of neuropathic pain. And it turns out if we can harness the activity of the motor system, we can treat a lot of new types of pain syndromes. So take, for example, chronic post-stroke pain. About a third of all patients who have strokes develop pain in the affected paralyzed distribution of the body, including the arm, leg, or whatever. And as you recall from a stroke, that's a brain injury. The spinal cord, alpha motor neurons in the peripheral nerves are all intact. So we can place peripheral nerve stimulators and stimulate and activate the motor system so that we can achieve motor contractions and subsequent pain relief. And it turns out this strategy is very effective at treating pain. And those of you familiar with this work in brachial plexus reconstructions and the reduction in avulsion pain after motor recovery from brachial plexus injuries after repair, this notion where activating the motor system to attenuate pain levels begins to make some sense. We don't know exactly why this happens. We just know that it happens, and we can harness that with peripheral nerve stimulators and stimulating motor pathways. Another exciting advancement, which is something that we're realizing the past couple of years, is that peripheral nerve stimulators don't even need to be placed permanently. There's a dedicated system where the electrode is placed for up to 60 days at a time. At the end of the 60-day period, the electrode is removed. And interestingly, the patients are showing durable pain relief, even for years after the electrode is removed. And initially, it seems counterintuitive, and it's still somewhat counterintuitive. But studies are showing that when you have the electrode in place, the patients have relief of the pain. What it seems to do is break this chronic cycle of pain, and it allows the brain to reset, probably through some cortical and subcortical reorganization. And what that does is it reverses the patient's chronic pain state and allows them to experience more durable pain relief even after removal of the electrode. And so that's a very interesting concept. And that opens the door to a lot of different, again, pain states where we can not only harness the motor nerves to treat pain, but do this in a way that the patients don't need a permanent implant. And so one of the hot areas of study now is treating patients with chronic low back pain. And think of how many patients worldwide have chronic low back pain. By putting in motor peripheral nerve stimulators, ultrasound guided, to trigger activity in the paraspinal muscles, the multifidus muscles, with a lead that's only in for 60 days, producing immediate pain relief that then persists after the leads are removed. And this is being looked at in these prospective clinical studies. It's a very, very promising area that can help hundreds of thousands, if not millions of patients worldwide. So this is something to keep an eye on in the next few years. Another exciting development in peripheral nerve stimulation is the use of these devices in patients that do not have chronic neuropathic pain, but instead have acute postoperative pain. So there's a whole area of research placing peripheral nerve stimulator electrodes in patients who have surgery in the extremities. And what we're seeing is that the stimulation actually reduces acute postoperative pain compared to placebo. So that's an exciting development because this allows patients to get pain relief without relying so much on opioids, right? So these opioid sparing therapies can potentially reduce not only the acute pill burden, but the risk of long-term development of substance use disorders. So again, peripheral nerve stimulation is an exciting field. Those of us who do peripheral nerve surgery should at least be aware of it. And I would argue that a lot of us should be doing these ourselves. There is an abundant physician industry innovation going on. It's producing rapid advancements. We're treating patients with complex craniofacial pain disorders, headache disorders, brain disorders, cognitive disorders, chronic and acute pain. This is a minimally invasive, safe, effective, and now evidence-based procedure that I think is a great thing to incorporate into all of our peripheral nerve practices. So thank you again for the opportunity to speak here. Happy to address questions later. And I wish everyone the best of luck and look forward to seeing everyone soon.
Thank you very much, Christopher, for this fascinating presentation. Actually, it was a pleasure to have such great talk in our event today. And now we move to our last speaker, Professor Carlos Aquives from Mexico is going to speak about the Ramsay-Hunt syndrome and facial palsy, when to perform nerve decompression. After this talk, we are going to have open discussion moderated by Professor Lucas Rasulik.
Dr. Morning. Yes, you can see my screen. Good morning. It is a pleasure for being part of this peripheral nerve surgery symposium. Thank you, Professor El-Ghandour and Professor Rasulik for the invitation. Now I'm going to talk about our experience with palsy related with Ramsay syndrome. We should consider face as a point for expression and personal communication. Facial nerve function goes to eye protection, speech regulation, chewing, swallowing, and emotional expression. So a facial pulse is not only a consequence of impairment, but also logical of a facial appearance. Ram syndrome is a cause of non-traumatic facial paralysis produced by varicella virus infection. Is a result of a geniculitis and characterized by pulse, ear pain, vesicular disruption, the ear, palate, tongue, accompanying other cranial disease that lead to loss or function. As you know, facial is a mix of the following fibers travel this structure, efferent motors from the motor nucleus muscles, general somatic fiber external, special and taste from the anterior of the tongue, traveling by coronary nerve, special vis efferent parasympathetic fiber, salivary gland, also traveling the tympani, and also fibers to glands through petrosal nerve. These anatomical ways explain the constellation of symptoms when infection activates with the geniculate gland. The physiology, quiet manner, the viral infection elicits inflammatory response with lymphatic infiltration. This rewards viral neuritis, okay? Using edema and ischemia, facial nerve and narrow space. So the result is progressive neuropathy of the facial nerve. All these factors lead to a cycle. Reported in 1997, this large retrospective is concerning Ram syndrome that demonstrate statistically significant improvement in patients treated with cyclovir and prednisone given 3 days of on. Despite of random control prospective trials for this condition, that collective reports and expected results suggest both medication given early improve the outcomes. Unfortunately, there is no information yet how to deal with cases. This show experience in with 6 cases that see as age, the side, the time elapsed for surgical detection, surgical and electrical findings are here. As you can see, all of them were with incomplete or inadequate pharmacological management, and also all of them suffer a severe clinical deficit with a House scale. In showed hyperintensity and an intense contrast enforcement of facial from the ganglia, the mastoid segment of facial, all cases of prepared electrodiagnostic studies showed the amplitude greater than 6% and denervation, which were recurrent things in all cases. In this video, we see the electro change of active vision, and also it's possible to the characteristic audible sign produce denervations. Now listen. That's a denervation. Now, why surgery? Despite lack of publications concerning this topic, it's reasonable to put microsurgery compression as an additional to refractory if we consider the pathology described. I mean, those patients that do not respond initial conservative management with and oral intravenous virals, palsy persistent 2 months at the onset of disease. Plasmastoid approach selected because of reasons. Rapidity, and up complications, and all its selection influenced by the compression. I mean, when more probe involvement is detected, middle force approach is probable, but this was not the case in our studies. And the main objective was to the facial nerve in the facial nerve from the Latin segment, stylomastoid, a careful surgical technique, bone removal. You can see video and the funding And surgical procedure in some cases continued, electromyography and muscle action potentials were recorded. I appreciate the results after the completion in one patient here, and it is important to mention that the clinical relates or clinical recovery relates with the improvement in the electro registry at the end of surgery. Another case, and the tables house Bragman before and after the compression cases observed the improvement in them. It has been written before. Many years ago, look at the 1934, before the introduction of antiviral and corticosteroid therapy. Surgical compression was a of choice. This paper said that in certain cases with articulate ganglion, the compression is useful. Unfortunately, the report experience in literature, and at the present, what the literature says concerning the surgery management of policy in this, well, one of the most systematic reviews not even mention surgical decompression as an option, but a limited number of describe its utility when some concerns are noted. And basically, the main indicators for those refractory tests that do improve with antiviral and steroid therapy, and in cases with the severe neurodegeneration by operative electrodiagnostic study. In this paper, the concentrations are the same, and it is relevant that in both the authors had full recovery only in 2% of patients treated medication. So, the reason they consider surgical decompression an option. The factors influence the outcomes after the acute palsy syndrome. Most important are the severity of symptoms at the beginning and the delayed treatment. So, reason a referral for sure is essential. And one important and critical to consider decompression early as possible is axon degeneration, as I mentioned it, identify electroneurology or myography, and comorbidity and age have a negative influence for the process. One interesting observation during revision, when time and proper management was in 50 cases, outcomes were better with surgical decompression, as you see in the right side. And conclusion for electrodiagnostic studies. Well, they are useful to stratify in severity. Therefore, exists a reduction in amplitude equal or than 10% with the collateral side, and if axon generation is equal or higher than 90%, according to literature, findings are indication surgical decompression and have usually double improvement function. So for us, electrodiagnostic studies are very useful. Not to succeed the best surgical approach. So what we recommend, first, consider the level of injury and potential implications, by example, loss, seizures, risk of infection with middle fossa approach. So for that reason, the surgical you know best. And our last case, despite little number of patients, lack of a proper trial take into the existing reports and all, we can that referral early protocol management imperatives. Those with inadequate clinical management progress to refractory presentation. Electrodiagnostic duties are helpful for the identification of potential candidate, and if the patient surgery, do it for 2 months. Otherwise, of nerve degeneration could leave possible damage. Okay. Finally, as previously, literature it is necessary to perform design trials to reach the utility of decompression more scientific support. So, thank you very much for the attention and for the invitation.
Thank you, Carlos, for this presentation. Nasser, please.
Thank you very much, Carlos, for this presentation. And now we open discussion among the panel, and maybe you have some questions or comments over the Q&A panel or the chat panel. Let me first, I think many people raised their hands. Anybody would like to make any comments? Ahmed?
I think everyone should go out and get their zoster vaccine.
Professor Faiz Obaid, are you here? Faiz sent me a message. He is president of Jordan Society of Neurosurgery. Would like to make comment until he joins. May I ask anybody who would like to make any comments? Hisham Basyouni.
Yes, maybe one question about the technique to the very nice presentation about the new techniques, Professor Betzberg. I enjoyed it very much. What is the time interval you take for the stretching of the nerve with the fixateur externe? What time does it take?
So what we do is we think about stretching a nerve at 1 millimeter a day. So there's a fair amount of literature that would support that a nerve can be stretched at 1 millimeter a day, and a lot of that's based on the orthopedic literature where they grow limbs that are a little shorter than the other limb. So that's what we do. We extend the knee and we look at our angles and we say we can get back 1 millimeter of growth. And so we depending on the patient and how they're built and so on, we're going to extend saying we can go so many degrees per day or every few days, depending on where the patient lives and so on. We'll bring them in, or we get a family member to work on the external fixator and take the degrees down. And basically you can get them straight within 2 to 3 months. Some patients it's been as much as 4 months and they've got a pretty straight or stiff knee. But so far we've been able to rehab everybody where the knee comes back to a good function. And this isn't, my technique. This has been around for a while, but we do find the external fixator being a tremendous help in getting this done.
Interesting. Thank you.
Professor Faiz Obaid, he's here. He would like to ask a question. I can see. He raised his hand.
Faiz, you already in the panel. Please unmute your mic and start to speak.
Hello.
Hello.
Hello. Hello.
We can hear you.
Oh, hello. Good day for everyone. My name is Faiz Obaid from Jordan. I have to ask about brachial plexus injury due to gunshot injury. Especially those days we received a lot of cases from Yemen injuries and cases from Libya, from Syrian explosion. So most of the cases, they are multiple anatomical injuries and they are associated with vascular injuries. They are also potentially infected. I don't know what's your advice to explore it immediately or observe for a while and late exploration. So I need to really to listen your advice from the pioneers in brachial plexus surgery.
Thank you for this question. Who would like to answer?
Well, Lucas, you're probably the one that has the most extensive experience with that.
Yep. Well, if I can say something, this is I would say a question which is with gunshot injuries. There is algorithm for treatment of gunshot injuries in all peripheral nerve system lesions as well as in the brachial plexus. But you have to have I don't know your situation in the field. But generally speaking, a lot of these cases recover spontaneously, and this is general talk about this. In each individual case, you have to evaluate the patient. But if you explore the plexus early, this is due to some other reason, not due to the plexus repair in gunshot injuries. So
okay.
If you have vascular lesions associated or bone injuries, then you have to explore the area, the region. Then you can explore the plexus and you can see what is your intraoperative finding, and then you can see how you can deal with that. In case if there is another possibility for treatment, you should wait for at least 3 months to see if there is any kind of spontaneous recovery.
Thank you.
Yeah, I would agree with Luca on that. When we have a vascular injury with the patients, we always explore. So a patient who has a subclavian artery injury or an axillary artery injury and the vascular surgeons are needed to stop the bleeding or deal with that, those patients very commonly have a very severe nerve injury associated with it. Often some of the nerves have been transected. We'll either repair them then, mark them and come back, depending on exactly what we find. If there's not a vascular injury, it's much more than likely to be a concussive injury only. And those are the patients we wait on. Some recover, some don't, but we wait on those. So the vascular really does separate them out.
Great.
Any other question, comment?
Thank you. Thank you.
Thank you. There was a question from the chat about operation of the air palsy. Would you like somebody to comment about this?
Which palsy?
Erb's palsy. Erb's palsy. Herb Duchenne palsy, which is.
And what was the question?
Congenital.
Question was, do we operate Herb Duchenne palsy?
Sure.
Yeah, we of course, but obviously, question is applied with an experience. So this is something which we should say yes. There is a clear indication for operation of this patient. So,
is it a timing? Is it a timing question? Is that what they're asking?
No, just it was written. This is just a question about do we operate Erb's palsy? This is a. So you can find in the chat question. I will go through the presentations from the beginning. Alan, congratulations for the presentation. This is a real, I would say we have to do something with the lower extremity, with different kind of lesions and different kind of possibility for nerve repair, especially nerve transfers. But this is also very important issue that you presented, and I don't know if many people has an opportunity to provide this to the patient, this kind of multidisciplinary approach and possibility to follow the patient for 3 months and to learn the patient how to do it, how to treat it in his his city or where he lives. But generally speaking, this is very, very, very important, especially for this. What is your opinion about artificial conduits, such as, yeah, I mean, I'm asking you, but everybody's more than welcome to give the opinion, because I saw a lot of cases operated in different centers in the United States with Neurogen devices, artificial conduits with 7 centimeters or even longer repair, even with cadaver let's say selected grafts.
So there's a couple, that's obviously that's a webinar in itself. Couple of questions or a couple of things with that. Number one, the artificial, when you say oxygen's not artificial, right? That's detergent washed cadaver. So it's allograft. And allograft is now being shown to be useful in about a 1 to 3 centimeter gap. Past 1 to 3 centimeters, the data is very iffy. At less than 1 centimeter, the data is very good. And at 1 to 3 centimeters, it's questionable. So that seems to be for motor, repair. Sensory repair is a different question, but for the mixed motor nerve, the detergent washed allograft doesn't seem to be terribly good past 3 centimeters. The artificial, so a conduit that is truly artificial without injected growth factors or other factors, same thing. 1 centimeter gap is about all they're able to show for good motor recovery on something like that. The bigger question, and it's my question, what I would love to hear some comments from this illustrious group, is an end-to-end sciatica repair at the level of the buttock crease that's showing motor functional recovery at 8 months, showing plantar flexion. How do you explain that? That goes against all of our teaching that at least my mentors taught me. It just doesn't make sense. We have some theories now, and we're testing these in the lab, but I'd love some input from anybody else.
I would say biological challenge to think about this. This is, we don't have any, lot of cases, very few cases with this kind of repair. And this is not good recovery, like in practically majority of cases. But I believe that some possibility for biological repair can appear in these cases like you present.
Alan, is it possible that a little bit of tension on the nerve as it's recovering helps it recover faster? I don't know why that would be, but could that be a potential mechanism?
So that's what we're testing right now. We did a tension-free repair. We left it completely alone for a month and a half to allow the repair to get some recovery. Then we put in what's called a growing rod in the femur, and we started to grow the femur at 1 millimeter a day. So the question is, did that tension, that force on the nerve that we know a normal nerve can tolerate and will grow, right? People can grow limbs. Did that speed up neural regeneration, that tension force? And that's what we're testing in the lab right now to see if that's true. It's not been reported. It doesn't make sense that it would be true, but we've got a model we've set up and we're testing it. I don't have a better explanation. So far, that's my only explanation. But as I say, that patient in 8 months is showing plantar flexion, which is continuing to improve. And at 8 months after a proximal injury like that, it makes absolutely no sense.
Well, compression helps bone heal faster and better. So maybe stretch helps nerve heal faster and better.
Well, so this goes along with the Tessa Gordon. If you do the electrical stim, we improve or hasten neural regeneration. Maybe tension after the nerve has had a chance to cross the repair site, so you don't ruin your repair site. Maybe tension becomes a good thing. And as I say, we're looking at that biologically now in the lab, but very, very unclear. I don't have a good explanation for it. I really don't. I was absolutely astounded to see that.
Thank you. Any other comment?
Christian, go off mute.
Yeah.
So, Ellen, thanks a lot for this very impressive talk. We were talking about the really, really fantastic tibial function, but did you see any peroneal?
So he's not, again, put this in perspective. I did the repair July 30th.
See, I know this is incredible.
So it's incredible, right? So right now, and unfortunately, I'm in Baltimore. He lives in Texas. He's 1,000 miles away. We've been doing this by video. I've not seen any recovery yet in the perineal distribution, but he does have a Tinel's. And when he taps in his popliteal fossa, he's getting a Tinel's sign down onto the top of the foot. He's feeling it more on the top of the foot than on the bottom of the foot. And yet he's showing us some plantar flexion on the video.
Because maybe I think that there are a lot of factors that influence on nerve growth we still don't have any clue of. I think there will be epigenetic factors that, well, I mean, first he's young, he's tall. This is, disadvantage, but he's young.
Yes.
So maybe his, somehow growth system has not completely stopped. So maybe this may facilitate too this tremendous success. But I think there are a lot of factors not known yet that will come to light maybe in the coming years. And regarding the peroneal nerve, because I changed my attitude towards him, because I don't know how about the others, but the peroneal grafts, no matter if they are done instantly or if they are done long term, especially in the traction neuromas, they don't work. Or they work, well, if they work okay, it's already enough. So we changed our routines and became more aggressive with the tibial posterior tendon transfer. Do you agree on that?
I
So
agree. I agree completely.
So I agree with you. One of the things we've been looking at is the perineal tract. There's two very different groups. One is a perineal traction injury or stretch injury, and the other is the more proximal injury that comes from a stretch injury from a hip replacement or something more proximal. No question that we're missing a lot of patients that have a traction injury around the knee and the nerve is avulsed from the muscle. What we don't recognize is that you're actually avulsing that nerve out of tibialis anterior. And if you do the histology, you see that the neuromuscular junctions are completely disrupted. And that's, I think, why our grafts and repairs don't work well with a traction injury at the level of the knee. So that's one group. The other group is the ones who have a more proximal injury. And for whatever reason, we think it's just time. It takes so long for that tibial nerve to regenerate, or the perineal nerve to regenerate down. By the time it gets down to the tibialis anterior, the muscle's terrible. So in that group of patients, they have the advancing Tinel sign. They get a beautiful Tinels at the fibular head, and yet they never seem to get back good motor function. So that group we've now treated differently. That group we're doing, some people will do distal nerve transfers immediately. Often that patient doesn't have a good tibial nerve, and we found that our distal nerve transfers don't work well. We've gone to a very different approach, which that's why my last slide was saying. We still don't have data on this, but we've been doing it. So I'm waiting to collect data on my patients before I claim that it works. But we've been going to distal muscle transfer and then reinnervating our muscle transfer with the perineal nerve after giving it time to regenerate. So it's not a free muscle transfer. We're bringing the gastroc around, the lateral gastroc, and then reinnervating it with a perineal nerve. And we're getting some results on this, some fairly good results. But I don't have enough data to really say that's true. But we're getting there.
Thank you.
It's called we're calling it a modified Ninkovich, because Ninkovich was the one who described the actual transfer of the muscle. But what we've modified it with is we're cutting the nerve to that muscle and now using that perineal nerve that's had time to regenerate and reinnervate the muscle.
Deborah, you would like to say something?
Yes, I'd like to comment on the treatment of common peroneal nerves. So I think I have quite an experience with these cases, and my present guidelines for treatment are: if I explore the common peroneal nerve and I found out that the neuroma that has to be resected as related to a gap that is between 3 and 6 centimeters, I do perform a nerve graft, nerve repair, and I have to say I have seen successful results, favorable outcome. But whenever the gap in between the two stems is longer than 5, I will always associate a posterior tendon transfer. So basically, it's a little bit like what you said about the tumors. We have to tailor the procedure. So you explore the nerve, and I have to say also the timing and the age of the patient is important. A young patient may be allowed to do better with maybe a longer graft, but I would say that I feel safe if the graft is going to be 3 or 4 centimeters. Otherwise, if the gap is longer, like 5 or 6, if the patient is young, I can still rely on that. If the patient is like over 35, I would probably go and associate the posterior tendon transfer. And if the gap is longer than 6 centimeters, for sure, I'm going to do the nerve graft and associate the posterior tendon transfer.
This is our experience too. If we combine in the young, and
Yeah.
they have both regenerating peroneal and the tendon transfer, they will have a really nice function. They go back to jogging and do sports.
Yes, this is
But because the combination of the two, which means that you reestablish the imbalance between the anterior and the posterior compartment of the leg, is what provides the best results. But again, I have to say, I tried a few cases without the posterior tendon, just because, you know, the patients were referred to me kind of rather early after the injury. And I saw that the gap was actually a short gap, and I tried just with the graft. And in those cases, the patients were presented successful recovery. And in that, otherwise I would have, you know, associated the tendon transfer maybe later if I saw that there was no potential for spontaneous recovery. So this is now my technique. I explore and I see how long is the gap. If it's if it's shorter than 5, just the graft. If it's longer, then I always associate the tendon transfer.
Thank you, Deborah. Any other comment?
Well, I'll add, if you're going to do that, one of the things we've learned the hard way, so to speak, from experience, is if I'm going to graft a common peroneal nerve that's had a stretch injury, you have to explore that nerve proximal all the way to the junction with tibia. So you got to be way up in the sciatic nerve, because it's not uncommon that you have a stretch right at the level of the popliteal fossa or distal towards the fibular head. You go to graft that area, but when you go real proximal, look at where the nerve is leaving its tibial component, there's another neuroma sitting there. There's a neuroma sitting right at that proximal part. And so we've learned that the hard way, where we've gone back on our own failures, and we realize it's a very diffuse injury, and you have to go very, very proximal to get above where that injury truly starts. So
yeah, this is true. This is true, especially considering what is the causative mechanism of the injury. If we are talking about knee distortions, that's for sure. You have to trace the nerve back to the origin from the sciatic nerve. But talking about other mechanisms, like for instance, iatrogenic injuries or stab injuries or gunshot injuries, where you can expect that there is not really a traction, but there has been a more focalized damage, then, you know, sorry, in those cases, this is when you can just rely on the nerve graft.
100% agree.
Alan, we use imaging preoperatively to do that exploration rather than incisions, but it accomplishes the same thing.
Yeah, I do both now because I've been burned even with imaging.
Wow.
And so I think with some of the really new imaging, really good quality ultrasound and MRI neurography, okay, I'll rely on it a little bit. But as Deborah says, if it's a traction injury, I always try to get up there really high and make sure I'm above the injury, because it's diffuse. It's usually a very diffuse injury.
Agree completely. Any other comment? We can go for next presentation, retroperitoneal tumors, tailored approach by Professor Christian Heinen. Any comment for this presentation? Christian, congratulations. Excellent presentation like usual. And we have a little correspondence with about this in neurosurgery.
Yes.
Any comment? If not, we can go for another presentation, which is also very exciting presentation and very important presentation regarding peripheral neurostimulation for chronic neuropathic pain by Professor Christopher Winfried. Any comment? Chris, excellent presentation.
Thank you.
I have a patient operated twice three times in another institution, amputee patient, long time ago during the war period in former Yugoslavia, both leg amputees. He has a extremely severe pain in his left leg, and 3 times operated resection of neuroma in another institution. Now is operated twice by me, and all kind of operations were done in the previous period. Generally speaking, this is not functioning. He has a severe pain at all. Now we are thinking about stimulation. What kind of stimulation we should recommend for this patient?
I mean, it depends on what you have available. I usually give patients 1 or 2 chances with surgery to correct a structural problem.
Yeah.
And if surgery doesn't work, I stop and then offer neuromodulation. If the pain is in a peripheral nerve distribution, then a peripheral nerve stimulator is reasonable if you have that as an option. If it's a phantom pain or one that spans more than one territory, then probably a spinal stimulator, either dorsal root ganglion stimulator to target the relevant dermatomes, or just a dorsal column stimulator, a spinal cord stimulator. That'll give you the most coverage, and it's best if it's bilateral lower extremity pain. So a single spinal cord stimulator electrode can cover all of both legs. So that may be your best option if he's a bilateral amputee with pain. That's what I would recommend.
Thank you.
It's technically the easiest to perform also.
Yeah, we'll start from the easiest modality. Christian.
So, Chris, thanks a lot for this fantastic presentation. I think the main issue in these patients is to get a clear indication, or as clear as possible. Do you follow a certain routine, or what are your prerequisites to have people operated on?
So as a nerve surgeon, I'm obviously not anti-surgery. So if there is a surgically correctable problem, like a neuroma or nerve injury, then I think it's reasonable to give patients a structural solution as a first choice. A lot of patients, however, have no discernible lesion that we can realistically fix with surgery. And in that case, patients undergo pain management, the neuropathic pain medications, injections. They undergo psychological screening. There's a set protocol for doing all of these things before offering the patients a stimulator. And generally, if a patient has pain in a peripheral nerve distribution, we offer peripheral nerve stimulation as the simplest, least invasive, lowest risk neuromodulation option. If patients have dermatomal pain, say knee pain, groin pain, top of the foot pain, then a dorsal root ganglion stimulator might be a good option if a peripheral nerve stimulator won't realistically cover the painful area. Anything else that's more regional, or let's say they have foraminal stenosis and cannot get a dorsal root ganglion stimulator, we offer spinal cord stimulation, which again offers the best regional coverage of pain in a body part, extremity, etc.
Thank you. Any other comment? If not, we can continue for the discussion for last presentation, Ramsay-Hunt syndrome and facial palsy, when to perform nerve decompression. Carlos, thank you for the presentation. There were little problems with audio, but generally speaking, presentation was excellent. And any comment about the presentation? Any question, remark?
Excuse me about the audio. Well, Lucas, I think maybe I have to add to my conclusions that it is important education, and it is important that first contact doctors be aware about this condition, because the majority of patients look for attention in this setting. So for us, maybe the number of patients received here in the office or in the hospital is a very reduced number, but this doesn't mean that the condition does not exist out there. Okay, so it is important education, and I think this is my best recommendation. Thank you very much for the opportunity.
Thank you.
To present this.
Thank you. Any other comments? If not, I cannot see all the screens. If somebody's raising hand, please just turn on your microphone and continue. But because I cannot see all screens at the same time, we have one question from the participants. one more question. There are no other questions. What is the ideal approach to the delayed panplexus birth palsy? No recovery at the age of patient 4. This is a question from the participants in the chat. Somebody would like to give a comment? Deborah.
I mean, at that point, it's probably no longer a nerve issue. It's maybe a shoulder stabilization issue with muscle transfers and things. I don't know that there's a nerve option that far out.
That's true. That is the correct answer. It's just to make a comment on the question. This was an idea. Thank you, Chris. Deborah.
First of all, I think we should actually try to understand exactly what kind of brachial plexus injury we talk about, because, for instance, we know that there is a difference when we have children that present Horner sign and non-Horner sign in complete palsy. So if you have a patient that has a complete palsy with Horner sign, we know that this is usually to be consistent with avulsions of the lower roots, and we have to pay attention to the fact that in babies you can actually have an Horner sign also for avulsions of C7 differently from what happens in the adults. So if you have an Horner sign, I definitely think this child should be screened with an MRI. If the patient doesn't have an Horner sign, there might be a possibility that there are not avulsion injuries. Now, and we should know exactly if it's like a complete palsy, like an M0 on everything. But I think it might be worthy to make an attempt to do at least a renervation of the shoulder with the spinal accessory nerve, and maybe also consider to use the intercostals for the biceps. I mean, we know that in obstetrical palsies, we do not have a muscle atrophy like we have in the adults. So this is something that might be tried, and then you still have the option for the muscle transfers. But again, the main point is try to assess exactly what kind of injury pattern the child has. And if we are talking about a child that has no recovery at all, but usually even in complete palsies, in obstetrical palsies, after a while, they do present some degree of recovery, which is of course not functional valid, but that could be, something, a starting point.
Thank you. Any other comment?
Well, I think one thing that is left out is, or a lot of times, is the sensory function. So we know that we can reach some reasonable sensitive reinnervation even after a long time. And I think to have a kid using the hand is a very important goal in these kind of procedures. So I think there's, well, at least a consideration is to be done as from a neurosurgical or a nerve surgical point of view. I think it's not only motor.
Thank you. Any other comment? We can comment presentation of Professor Hersham Elsovsky, since we have a very exciting discussion at the moment, and we have to continue with the presentation, so we didn't make any comment about the non-traction injuries of brachial plexus. If anybody would like to comment, Hersham, thank you for the presentation. If not, I'm not seeing any other question in the chat and Q&A box. I think we did a great job, and I would like to thank you all for these presentations and this activity. Nasser, I would kind of like you to conclude this webinar. I will say just a few more words. This is an activity which is within the members of the WFNS Committee for Peripheral Nerve Surgery. It's quite usual when we have our regular meetings, in-person meetings and conferences. Our discussions are lasting very, very long, and this is why we are very let's say, interesting for the participants. I would like to believe that discussions are always provocative and trying to push our borders in the treatment of our patients. So I hope this webinar was useful to all participants to understand and learn about peripheral nerve surgery. I would like to thank all panelists, all presenters with their outstanding presentation. And it's my great pleasure to serve as a WFNS committee chairman and to collaborate with all of you. And I really do hope that we will see you all in person very soon. I don't know when, but very soon. Thank you very much for your outstanding contribution. Nasser.
Thank you, Lucas, very much. It was an outstanding educational symposium about one of the important subspecialties, which is peripheral nerve surgery. Actually, I enjoyed the discussion, which was very interesting, and everybody enjoyed the session. It was one of the most successful webinars we have ever organized. At the end of this webinar, I would like to thank Professor Lucas Rasulik, President of the Committee of Peripheral Nerve Surgery, World Federation of Surgical Societies. Lucas, really, I enjoy working with you, and I'm happy about such collaboration, and we are looking forward for more collaboration in the future. I would like to thank all our distinguished speakers who gave us much of their time and their experience, and for sharing in the neurosurgical education process among young neurosurgeons, especially in our African continent. Thank you very much. May I not forget to thank my organizing team, Mr. Ahmed Magdi and Dr. Hassan Ala. Really are doing a professional job in such organization. Thanks to attendees, thanks to all of you, and see you next Friday at the usual time in webinar number 42. Thank you very much.
Thank you, Nasser. Congratulations.
Thank you, Lucas. Thank you very much, my brother.
Thank you.
Thank you. Thank you very much.
Bye-bye.
Lucas. Thank you, Lucas, very much. Thank you, my brother. Appreciating. Thank you very much. Thank you very much. Thank you. Goodbye. Thank you, Lucas. Goodbye.